exhibition which is going to be on. That's an area also towards networking and looking into greater business opportunities. That continues till 4 o'clock. So hall number 2, people who are interested in being a part of networking and looking into greater business opportunities, the startup session, they're requested to move to hall number 2. In hall number 1, this is a session which is dedicated to CSR, wherein we are going to be also having the presentation of the first CSR Health Awards by NATHEALTH, wherein joining us will be the Honorable Minister for Women and Child Development, Shrimati Smriti Irani. So request people to take your seats as soon as possible. Have your mobile phones on the silent mode so that we are in time for our session. Meanwhile, let me... Yeah. So let me also express our thanks to all our sponsors, our partners in success for the support which they have given to NATHEALTH in organizing this event. Many thanks to our gold sponsors, Dr. Lal Path Labs, Apollo Hospitals, Fortis Healthcare Limited, to HCL Healthcare and to Acumentis Infinity. To our silver sponsors, Metropolis Healthcare, Polymed, GE Healthcare, to Vigon, then Siemens Healthineers, Mahajan Imaging, PD Hinduja Hospital and MRC, and Roche Diagnostic, Johnson & Johnson, and Philips. We have our business pavilions, as I mentioned, that's in Hall 2. So that's by Saha Mantran Private Limited, also by USAID supported Samriddh Healthcare Blended Finance Facility, the Medical Education and Drugs Department, Government of Maharashtra, and the International Finance Corporation, and by Uzbekistan. We also, our session sponsors, NATHEALTH Healthcare Initiative Limited, Terumo India Private Limited, to BPL, thanking Vocard, Healthium, Medtronic, and Medica Hospitals. And thanking also Protype, which is also one of our session sponsors. In fact, as we mentioned yesterday, in these 2 days, we have close to 120 speakers who are addressing us. And as a gratitude and regards and appreciation to our speakers, those joining us virtually and those present physically, we are going to be planting a group of 10 trees. 10 trees per speaker we are going to be planting, and that's in Maharashtra. That's the trees for tigers in Ramtek, Maharashtra. And that's towards our commitment towards casting more greener footprints as we all work in our business spaces, looking into profits, but at the same time taking care of our environment. So that's on behalf of the speakers. We thank all the speakers for your valuable time, for your views as you come in to share with us, to enrich our audience, and at the same time contributing to the green growth. Thank you. For the people today, we have the tea, the arrangements have been made at the end of the hall, so we are going to be having running tea so as to just be in time for our sessions. The tea is right now also on. People who are interested in picking up their teacups, you can do that and be with us. So we start on a little fresher note. Also, just to mention, and as you know, people who were there with us yesterday, this is, we're having this conference in a hybrid mode. So most of the speakers are joining us virtually, and we have, of course, speakers here and the delegates, some close to 200 plus delegates and participants joining us physically. The rest, more than 2,000 plus are there on the virtual mode. Throughout these 2 days, there have been various studies, white papers which have been released by NATHEALTH. They have been prepared in association with its knowledge partners, and all these are going to be also available on the summit's microsite. So I think we are in time for our first session. So good morning to all of you once again, and welcome to everyone. On behalf of NATHEALTH, I welcome you all to the day 2 of the 8th NATHEALTH Health Summit, which, as you know, is on the theme rebuilding, restructuring and reimagining resilient health systems in the post-pandemic era. And as we have been talking, that pandemic has definitely tested our resilience, not only as professionals, but also as individuals, as people, as citizens of this nation, and as habitants of this planet. And towards that, there has been a greater realization across, and as I said, across, this goes with the professionals, this goes with the corporate bodies, the government, the people at large, that we need to take care of our people, need to take care of our environment. So today, this day, ladies and gentlemen, is dedicated to CSR, the corporate social responsibility. CSR, as we all know, in fact, it has been in the very ethos of our country. Initially, it was as a philanthropy, which most of the bigger corporates used to do, various philanthropic work. But then it was in 2013 that the government of India made it as mandatory. With a little slow start and little hiccups in terms of debate also whether it should be mandatory or it should be voluntary, there has been a greater realization and sense among everyone that what is good for your people, what is good for your planet and your environment is definitely good also for your businesses. So it makes definitely good business sense to be doing CSR. And otherwise also, like we say in, as per our mythology and as per our various rituals and our Vedas, the good you do, the good is going to be coming back to you. For this is a circular world, circular economy. So there have been corporates who have been investing in CSR across sectors, and majorly now, today we are talking about the CSR in the health sector. And we also have seen that CSR has moved more to the slogan of CSR for future, that is taking care of the environment, the ethics, the ecosystem, and having your social footprints. So today in this day, we are going to be looking into the why, the how, and the where part of CSR in healthcare as we work towards reimagining more resilient health systems. And then we are also going to be recognizing some of the projects that have been able to make that real impact, real impressions on the ground. So with that, to give you from the organizers' side, to give you more insights into the day and into the CSR, I would like to request and invite Mr. Sunil Thakur, the Treasurer NATHEALTH and the partner Quadria Capital, for his welcome remarks and also for context setting.
Good morning, everyone. Distinguished guests and participants from the government, NATHEALTH members, friends from the industry and media, ladies and gentlemen, I welcome you all to the second day of NATHEALTH's 8th Annual Summit. After yesterday's action-packed deliberation that touched upon nuts and bolts of healthcare businesses and how newer versions of these components can help bring fundamental positive changes to healthcare delivery, we would like to shift gears to softer yet very important and powerful component for rebuilding, restructuring, and reimagining resilient healthcare system in India. That powerful tool is CSR. As we all know, over the last few years, CSR initiatives have been driving major impact in India's social sector, from education to sanitation to poverty to hunger to healthcare. CSR initiatives have the power to transform the nation for the better by uplifting its people, fortifying infrastructure capabilities, and enabling innovation through private sector funding. In fiscal year 2021 alone, the total CSR expenditure was estimated to be above 22,000 crore. While in the past, majority of the CSR funding has been directed more towards sectors like education and few other sectors, there has been a gradual trend towards emerging frontiers of healthcare and within that innovation, which is where we are now seeing the flow of CSR money going in. This trend came to a head at the time of pandemic that hit us 2 years back. The ensuing emergency led to more and more Indian corporates shifting the CSR focus towards healthcare over other sectors. This response saw approximately 26% of the CSR money that was spent moving towards healthcare in fiscal year 21. However, while this trend gave us the monetary prowess in supporting the healthcare, it wasn't sufficient. We felt that there is a need to collaborate to create capacity and capability to effectively allocate and manage these resources that are coming through CSR in the healthcare sector. NATHEALTH has taken that bold initiative. The initiative is to build a collaborative and thought leader platform to enable important levers to channelize CSR funds to deliver outsized returns to the nation's healthcare sector, more importantly to the society. Among the important areas of work that is being undertaken by NATHEALTH includes advocacy for enabling legislation, which is very important, creating awareness amongst all the stakeholders, capacity and capability building, and helping democratize product creation and access in the healthcare domain. In line with its initiative in this area, NATHEALTH and its partners for the session have put together today's well-curated program around CSR that will help us get a ringside perspective of the best practices in healthcare CSR as a pivot to driving innovation in healthcare, and how best to prioritize opportunities and engagement models in the healthcare sector through CSR funding. The perspective will be shared through the day's 3 sessions around CSR, starting with a presentation on best practices in healthcare CSR by Anant Bhagwati, partner at Bridgespan, and Ami Ganatra, principal at Bridgespan. That will be followed by a keynote address by Rizwan Koita, co-founder CTS Tech and Koita Foundation. He will talk about CSR as a pivot driving innovation in healthcare. Lastly, as part of the discussion agenda, we have a panel discussion on collaboration with CSR programs, prioritizing opportunities and engagement models, to be moderated by Preeta Venkatachalam, partner and head of market impact South Asia Bridgespan. These 3 sessions will be followed by the most exciting part of the program, which is the first NATHEALTH Healthcare CSR Awards. This is an important initiative undertaken by NATHEALTH to recognize and motivate programs and individuals who are making a difference to healthcare delivery through CSR programs. I won't steal the thunder from Dr. Shyama Nagarajan, Managing Director of Sahamantran, who will take us through the process of the entire award program and the overwhelming response that we got for the awards. Most importantly, she will do the honors of inviting the jury members and thanking them for the painstaking contribution in evaluation and selection of the winners. Last but not the least is the most awaited part of the program, the chief guest address. This will be by none other than our Honorable Minister of Women and Child Development, Srimati Smriti Irani. She has managed to find time from her ever-packed schedule to grace and honor the noble cause of NATHEALTH. We sincerely thank her for making time and helping us elevate the stature of this cause. With that, I would like to call upon the participants of this session.
Yeah, thank you, Mr. Thakur. Thank you for introducing us what has been the thought and idea behind NATHEALTH, promoting CSR in healthcare. And towards that, we, as you mentioned, we have the first CSR Healthcare Awards which are going to be presented. Also talking to us on how the entire day has been planned as we dig deeper into understanding CSR and the how, the where, and what of CSR. So we'll now first have a presentation on the best practices in healthcare CSR, and this in fact is based on a paper prepared by NATHEALTH and Bridgespan. Bridgespan in fact had interviewed almost 50 leaders, and it is based on that their views that this paper has been prepared, this report has been prepared. So I would like to invite our presenter, Mr. Anand Bhagwati, partner Bridgespan Group. And in fact, we would also like to thank Ms. Ami, who was along with, but he's going to be making the presentation, but thank you also, the principal Bridgespan Group, for preparing this report. Thank you.
Hi, good morning, everyone, and good morning to everyone online as well. It's the first time after many years seeing a group in person. I'm going to dive right into what Sunil mentioned very aptly, which is there is now a regulation which is taking a significant amount of money towards social impact. Just to ground you again on the number, above 20,000 crores per year, which is significant. And we spoke to a wide variety of experts and people to understand how well is this working? And is there a path to go from good to great? And is there a role for NATHEALTH to play in that? Needless to say, whatever we do is not sufficient. We are a country where we are going to have a massive burden of both diseases like NCDs as well as TB, etc. And it'll have a disproportionate effect on women and vulnerable groups. So it's not enough to do good. It's critical to be doing good at the maximum scale possible. And we asked experts around why this is important. As all of us know, all of us are in healthcare, whereas only 3% of expert doctors stay in rural areas, 70% of our population resides there. 80% of disease conditions can be mitigated with good primary preventative action, but this doesn't really happen. We interviewed over 50 CEOs, families, business leaders to really understand where are we today. And gratitude to NATHEALTH for organizing this, because this journey has become imperative. One thing we heard from everyone is there is very high intent to create maximum social impact. It was unanimous. The group also shared very honestly that today, while there is capital, we are not close to actually being great at this. And we asked why. I think this slide tells the picture significantly. Today, sub-size grants are the norm. What I mean by that is moment a grant size is of the region of 20 lakhs to 50 lakhs, and moment a grant size is 1 year in duration, it automatically means one cannot go to great, because there is a challenge of fragmentation and there is a challenge of short-term thinking. Imagine in the for-profit world, if all that we invested was 1 year in nature and all that we invested was small investments. Very few organizations will actually go to great. And this is a challenge which is there today. We asked the second question saying, CEOs, are you involved in this? 90% are involved, but a very large percentage of them are not involved enough. One of the things we heard from CEOs is we would like to take this on just like we take on investor presentations every quarter, and give us the freedom to actually treat this like a metric, just like we treat other matrices. This was a shocker. 60% of the companies have a significant disparity of income in terms of CSR heads compared to other equivalent business functions. The reality is we will get what we pay for. And as CEOs are starting to do more social impact, the real question is, are we treating this like charity, or are we treating this around creating real long-term value for the organization and for the country? The good news is there is already high alignment. 90% of CEOs we spoke to are involved in CSR activities in some shape. 90% of them say that they are willing to pool resources. It's music to ears to hear NATHEALTH is keen to be an enabler in that. Because as one starts pooling, one can do bigger, longer-term bets. A majority of firms have more than 5 people handling CSR. So there is teams which are doing this. And finally, a very large number of firms want to actually be involved in long-term delivery of some of these operations. We then asked a double-click question on saying, if all this is there, what is your biggest worry? And I want you to look at the size of each word in terms of the number of people who said that word. There's a huge question right now around trust. And there is a question around lack of impact or perceived lack of impact, which means if NATHEALTH can start creating transparency, saying this is the metric, this is how it's going, and this is how your company's money is being well utilized, it can turn around 2 of the biggest barriers we are seeing. And secondly, lack of structured vehicles to actually absorb this money in a way that it can be used over a longer term is quoted by many people as a barrier. Again, this is potentially something a group like NATHEALTH and the members can actually do something around. We asked what are the best practices and what would be the few things which need to be done to turn this around. I think 2 things jumped up very strongly to all the leaders we spoke with. One was focus on a few long-term equitable bets. What is equitable? Focusing on really the vulnerable sections of society. And secondly, collaborate with like-minded partners to put together resources to go behind these bets. Needless to say, there were other best practices also, but these 2 things came up loud and clear. And again, I was very happy to hear from Sunil, some of these are thoughts already that NATHEALTH is thinking about. To end, we asked them what hence could be some of these bolder bets. And a bold bet, as defined by Bridgespan, is a bet which is more than $5 million spread over 3 to 5 years, which consumes more than 80% of capital and effort of the giving entity. So very simply put, a bold bet is an effort to double down on a certain topic over the longer term. 3 things emerged. One was really developing primary preventative healthcare in aspirational districts, in the districts which are actually the most vulnerable in India. There are more than 100 such districts. Secondly, capacity building in tier 2 cities to bridge the gap of healthcare professionals, not just doctors, but nurses, as well as community health workers. And thirdly, what came loud and clear was skill development for healthcare professionals, through multiple initiatives to not just solve for health, but also create jobs. With that, I again circle back to the first point around, is it good enough to be good, or do we actually have to strive to get to great and to get to full potential? Thank you.
Thank you, sir, for sharing your study with us. As a token of our gratitude to you, we are going to be planting 10 trees at Roundtable, Maharashtra. That's Trees for Tigers. So thank you for supporting us in that initiative. Thank you. And now, ladies and gentlemen, we are going to be further exploring CSR as a major catalyst towards driving innovations in healthcare. And we have a keynote address towards that. Would like to invite our speaker, Mr. Rizwan Quetta, the co-founder, CITIUS Tech, Quetta Foundation.
Yeah, good morning, everyone. First of all, like Anand mentioned, it's such a pleasure joining a conference in person. I think we've had more of Zooms than we quite care about. And I also had the opportunity to wear a tie for the first time in 2.5 years, so thank you very much for giving me that opportunity as well. As I was preparing for the meeting today, I'll take a minute giving you my personal background. So we started a digital health company, CITIUS Tech, about 16 years back. And about 4 months back, I stepped down to pursue and spend more time in the philanthropy space. So a lot of what I'm going to be talking about today is also a relatively new topic for me. So I'm going to be sharing some of my early thoughts, and hopefully over the course of the next few years, as I spend more time in CSR and philanthropy in healthcare, my thoughts will get evolved. But I was also happy to see that a lot of what I'm saying is also consistent with what Anant mentioned after having spoken to a lot of people. So hopefully there is sort of more insights here. Wanted to start with giving a little bit of a context. This slide I've picked from the Central Square Foundation team. This kind of puts a little bit of context in terms of what is corporate CSR. So domestic CSR is about 14,000 crores a year. And even if you add all the individual philanthropy and all the other contributions, the total contribution in India across all sectors, they estimated about 64,000 crores. And if you take about, say, a third of that, and there are no sort of established numbers here in the market, but imagine we took a third of that, the total amount of monies that would probably go into healthcare would be in the range of about 20,000 crores. Yeah. So how does this number compare with money spent in healthcare overall? So if you look at government spending in healthcare, it's about 300,000 crores. Out-of-pocket spending by individuals about 600,000 crores. These are just gross numbers to just illustrate the point here. And you benchmark that to 20,000 crores, and you see that it's really a small drop in the ocean. And the real question is that, what can CSR or philanthropy do to enhance healthcare, and how can it become a pivot for driving healthcare innovation? Interestingly, if you look, I'm going to skip this slide in the interest of time, but overall, healthcare is spread across public sector and the private sector. And both these stakeholders, the public sector and private sector, have some characteristics which are quite unique to them. So if you look at the public sector, the focus is on providing core healthcare services, especially to the poor and the underserved. The ability and desire to innovate tends to be low because it's the public sector, so they want to kind of do things which are sort of in the territory of known, without necessarily expecting any return, because most of these services are provided through corpuses that are funded through taxes and other ways. If you look at the private sector, they want to provide healthcare services which are financially viable, financially attractive. The desire to innovate tends to be high, but typically a lot of the funding that goes into industry today has a 3 to 5 year, perhaps a 7-year time horizon, because a lot of it is coming through private equity money, it is coming through other forms of capital market funding, which tends to have at most a 5-7 year time frame. And what ends up happening is that any needs that are there which don't fit into one of these two models often are not being pursued as effectively. And the way CSR and philanthropy can work to really drive innovation is because it is a meaningful amount of money if spent right, and it can focus on areas which where the desire to get a payback is of a time frame which is slightly higher than what you would be able to do if you're only looking at private sector to be able to fund those needs. Also, CSR and public fund philanthropy can be very interesting because it can help us create models which can then be picked up by the government and spread at scale. We have the pleasure of having Sanjeev here, who runs the ECHO, the Project ECHO, and that's an example of something which has kind of gotten started, and it's a model that the governments around the world are starting to copy. And it's those kinds of things that hopefully CSR and philanthropy money is able to effectively fund. So going to my last slide here, what are the areas that the CSR and philanthropy funding can become an interesting lever for driving innovation in healthcare? And I've tried to break this up into three major groups. One is around trying to drive innovation and pilot programs. There are lots of areas which problems are unique to India as a developing country. And it's an area where we find that if CSR, philanthropy money could come in, it could certainly help. The second area is to be able to drive pilot programs in manner which you could establish proof of concepts, which can then be taken up by the public sector, by the government to be able to scale up. The second area is around capacity building. Capacity building is of basically two areas. One is in academic institutions. Creating programs in healthcare innovation, in digital health. These are areas where India needs a tremendous amount of capacity, which is currently underserved. The second one is to be able to train doctors, nurses, others at the grassroots level to be able to get access to newer forms of healthcare delivery and innovation. And the last group here is around regulatory and industry initiatives, which are the CSR and philanthropy money can play a really interesting role in ensuring that we are able to create the right focus in society so that whether it's government funding, whether it's other public initiatives, private initiatives are targeted in a certain way. We saw ample evidence of that during the COVID pandemic. The second one is to be able to support the creation of standards. Again, sort of financial programs, financial incentive standards play a very, very big role in healthcare. And CSR and philanthropy contributions to do research similar to the type of research, for example, that Britspan showed us, can play an important role in driving the regulations in the right way. And finally, there is a tremendous opportunity to be able to support collaboration between industry participants. The industry participants could be hospitals, it could be pharma organizations, it could be academic institutions, medical colleges, what have you. And if you're able to create the right forum for collaboration between these players, then we can see a very, very accelerated path to innovation compared to what we have right now. And a great example of that is the startup pitch event that has been organized by NATHEALTH would be an example of something like that, right? So in conclusion, a tremendous opportunity to use the very few precious dollars or rupees that we have in CSR and philanthropy, and if directed right, it can have a huge multiplier effect to improving healthcare and healthcare innovation. Yeah. Thank you very much. Yeah.
Thank you, sir. Really appreciate your sharing your thoughts on where you can actually put in your money in various areas, as you said, towards more towards preventive healthcare, towards capacity building, towards driving innovations, R&D, working closely with the academia, with the tech companies, and also appreciating the startup pitch session which NATHEALTH is holding, and that in way contributing towards greater driving innovations in technology, having the startup companies sharing their work here. Thank you, sir. So we are going to be now digging a little more deeper into the CSR, collaborations with the CSR programs, prioritizing opportunities and engagement models. That's the topic of the panel discussion which we have now. I invite our moderators first here to take center stage. Ms. Pritha Venkatachalam, Partner and Head of Market Impact, South Asia. She is going to be joining us virtually. If you can just have...
Hi, everyone.
Yeah, we can hear you. We'll just have you on our screens. And Mr. Anant Bhagwati, Partner, the Bridgespan Group. So two moderators of the session, inviting our speakers, Dr. H. Sudarshan Balal, the past President NATHEALTH and Chairman of Manipal Hospital Group, Dr. Alok Roy, Chairman Medica Super Speciality Hospital, Mr. Himanshu Sikka, Strategic Advisor, Samrid and Practice Lead of H&N Wash, IPE Global, Dr. Srinath Reddy, President of PHFI, and Dr. Sanjeev Arora, Founder and Director, Project ECHO. So welcome to all our speakers also joining us virtually and all present here. And with all in, we are good to start with our discussions, and I request our moderators to now take the proceedings of the session forward.
Thank you very much to everyone. I hope I'm audible.
Yeah, ma'am, audible.
Great.
Loud and clear.
So it's a pleasure to join this panel and talk about the impact of CSR and the potential of CSR for healthcare in India. We have heard Mr. Koita just now speak about healthcare innovations and how important leveraging every dollar that goes into healthcare is towards greater impact on health outcomes for India. Also, given hopefully if we are emerging out of the pandemic, there's a lot more investment going into healthcare systems. And I think it'll be critical to have this discussion to see how CSR can be a force multiplier in that. To begin with, we have a cast of eminent speakers, and we would love to hear from all of you about how some of the recent practices in CSR and some of the best practices that you're hearing about this morning resonate with your experience. So if you could talk to some of that, and we can begin with Dr. Balal and go on to Dr. Roy. To begin with, it'll be great to hear about what you've seen as best practice in CSR for healthcare.
Am I audible? Yeah. Very good morning, and my sincere thanks to NATHEALTH, the President, Dr. Maharaj and Siddhartha, for inviting me to this very important event. And on a lighter vein, having just come out from the prison of COVID, I'm glad that the organizers have socially distanced me from the rest of the crowd. Thank you for that. Be as it may, I think the topic for today is a very important topic for us. I think the brutal COVID waves, one after another, woke us up from the deep slumber of apathy towards healthcare, which was the silver lining of the COVID pandemic. It certainly pricked our conscience to see so many people suffering and die during this deadly pandemic. And believe it or not, people from all walks of life, people that I didn't know or people that I had not met for decades together, were calling me from all parts of the country and abroad, offering to help. They literally opened up their hearts and wallets during the COVID pandemic. And this came in the form of various oxygenators, ventilators, PPEs, masks, sanitizers, setting up of call centers, digital health, setting up of COVID care beds. And very importantly, I think in my mind, one of the biggest tragedies of COVID was the internal migration crisis. And a lot of people came forward to shelter them, offer them healthcare and food during these mile-long queues of people waiting to go back to their hometowns. So I think this was all very good. However, though these gestures were very valuable, that's not the beginning of the end of CSR. What we need, as was prominently mentioned by the previous speakers, is a model that is sustainable, scalable, long-term, and be directed to the most needy, and that has the greatest impact. And that's what's been lacking so far. We obviously have had spontaneous outbursts of your conscience pricking you and lots of money coming out to COVID. But that was more of what I would say a knee-jerk reaction to the sadness around you and the catastrophe around you. But what we need is something that will go long run in helping the healthcare of our country. I always say this, I mean, I know that Dr. Raghuvanshi is here in the audience, that sponsoring a few heart surgeries, brain surgeries, and my own field, kidney transplants or cancer surgeries, they're laudable, but they're really not the kind of CSRs that will take you long term. For one heart surgery or one kidney transplant that's sponsored, you can probably have an entire district of people given sanitation, clean water, and prevents millions of deaths. So I think we have to be moderate and sensible in what we do, especially when the resources are very limited. Please sponsor heart surgeries, transplants, whatever. But let us focus on what is really the need of the country. That's investment in prevention, primary care, public health, and with measurable outcomes, because we need to have some outcome that can be measured to make sure that what we're doing is the right thing. One major issue which I must compliment NATHEALTH for that is to be addressed is so far CSR has been in bits and pieces, and we need an aggregator or an enabler like NATHEALTH to channel these funds in the right direction. And I think that way the NATHEALTH has sort of started this in a big way, and I hope will go a long way in creating a fund of innovation and long-term healthcare in our country. All in all, CSR activities should be collaborative between private donors, governments, aggregators, or bodies like NATHEALTH, and let us all invest in strengthening the healthcare of our country. Thank you very much.
Thank you, Dr. Balal. I think that was a very, very important line that you ended with on the importance of collaborations. And the number of collaborations in the face of COVID has really doubled since pre-COVID. On that note, going on to Dr. Roy, if you could share your reflections on CSR best practices and what you see as the potential impact for CSR in the coming years.
Thank you very much. First of all, very happy and pleased to be here. For the last so many years, we have been talking to the screen. I have almost fallen in love with my iPad and forgotten that human beings exist beyond it. I was just thinking about CSR when all this came to me, and I'm just shy of 3 months of my 45 long years in healthcare. This July, I'll complete 45 years. Just wondering, what this CSR bullshit all about? Sorry for using bad words. Whatever our problems were 45 years back, continue the same. For a simple reason that we are providing healthcare at our doorsteps. All those who come to us, we treat them. As Dr. Balal has said, that we treat them sometime by giving a free cardiac surgery or pediatric surgery, and we think we are larger than God. The problem is at all three places: pre-hospital, hospital, and post-hospital. Pre-hospital is the most critical. Pre-hospital is truly where CSR must stay focused on, and it's a long-term, 5 years, 10 years, 20 years, 100-year plan, whatever plan you have depending on the growth. Because we all know that we don't have enough doctors, we don't have enough nurses, we don't have enough institutions to train them. So pre-hospital is one area. Even if you talk about screening, if we just screen in our neighborhood, 5,000 elderly who are above 60 years, for blood pressure and blood sugar, you will cut down on a stroke and heart attack substantially. Because these are the people who get stroke or who get heart attack and they land up with you, half of them have no money. Just sheer screening pre-hospital can prevent so many deaths and it can be sustainable. But the problem with CSR investor is the moment he gives you 1 rupee, he asks that how is it going to reflect in numbers, what is going to happen to money has been spent. That's one factor, which is very critical. Pre-hospital screening, teaching, training like ECO is doing, training, and preventive, just simple sheer vaccination. The digital, now everybody has a mobile phone. We can run hundreds of messages to them and most of them read it and all of them believe it. So if you really send a good information, which is comes from a reliable source, then probably we will prevent a lot more deaths. Youngsters, anybody who buys a bike, you can keep on telling him that helmet is important. It will save life. We see it every day. Every day we get 1 or 2 people brought dead in our different institutions or with the fracture or serious conditions. So pre-hospital is an area where CSR can stay focused for long-time sustainability, and it is something which we must request and we must talk to these companies for invest in that direction. Number 2, hospital we can't avoid. A lot of people who come for surgery, who come for various life-saving. Yesterday we had a rickshaw puller who was hit by a doctor's car and he had a severe subdural hemorrhage. We had to operate on him, he has no money. So some amount of money can go in providing care in the hospital and the post-hospital for caring. When you operate on such people, if you do not sustain them with the care, then the outcome is not optimal what you operate him for in the hospital. So if you ask me, I would say that 80% of the money of CSR must be spent pre-hospital. 15% in the hospital, 5% post-hospital. And that would be a sustainable model very clearly, which will complete the spectrum of care in our country, and especially in a country where 75% of the population does not have access to healthcare. So CSR can be a huge game changer, especially in pre-hospital, if we all of us join hands. And what Siddharth and NATHEALTH is trying to do is great. The biggest problem of healthcare is that first of all, there are very few people to donate for CSR in healthcare. There are very few. Most of it is done by the institutions themselves, or a little bit of help here and there. We all raise funds, some crore of rupees, and we like to invest in our own hospital preferably, because of whatever little I'm losing, I'll get it from there. That's my intent. So if there is a central body like NATHEALTH and they can channelize the CSR, develop the CSR protocols with individual hospitals in different locations. We all have hospitals in big cities, small towns. So we all can work sincerely. And it will also help our bottom line. And bottom line, not a typical financial bottom line, triple bottom line of our social standing in the society, which will give us, every poor has a rich relative who will be coming to us, providing us money. So I think I would look at CSR in these 3 segments, which could be useful to our country. Thank you very much.
Thank you, Dr. Roy. I think the importance of preventive and promotive care is really underestimated. So I'm glad you brought that up, and I hope forums like NATHEALTH can really canvas more action and more funding towards the pre-hospitalization care, as you called it. I'll move here to Dr. Reddy, and it'll be great to hear from you, sir, if what's been your experience with respect to CSR and philanthropy helping with healthcare, particularly primary healthcare, given the need of TAR?
Firstly, I completely agree that primary healthcare, which also encompasses a lot of public health interventions, apart from early detection and care of very common health conditions, is absolutely pivotal for the success of good health services being provided to people. And the COVID-19 pandemic has brought that into attention. It's not just the ventilators and advanced care, but the fact that early detection, early testing, ensuring vaccine administration, taking care of long COVID, contact tracing, all of these are essential functions of primary care even during a public health emergency like COVID. However, this has been long neglected. So how are we going to build a system where we have comprehensive, continuous, connected, chronic and acute care being delivered at home or close to home? And therefore, of course, we ought to have investment in technologies, investment in infrastructure. But that will only provide part of the solution. Without an adequately well-trained primary healthcare workforce closely connected to the community, this investment in infrastructure and technologies will only be a carriage without wheels. You actually need people who can deliver and connect even to the higher levels of care. Telehealth has brought in a great deal of innovation and a great deal of benefit, but you still need people at the front line to translate those benefits into reality. And I believe we ought to really look at connecting now, particularly with the 15th Finance Commission, entrusting the responsibility of primary care and a good deal of public health functions associated with that to local bodies, and the funds will be flowing to panchayats and municipal corporations. We must really look at how we actually build the capacity in those organizations to utilize those funds appropriately. So I believe that the trinity at the front lines of primary care will be of the frontline health workers, of the community, and of the local bodies, and we need to really bring them together in a close, concerted coalition. Now, we recognize that even in terms of CSR, agencies that have recognized this reality have started investing more in CSR rather than just in hospitals alone. Hospitals are needed, but they're not enough. For example, if you look at what the Gates Foundation has done, they initially invested a lot in technologies, but recognized that those technologies are not reaching the intended beneficiaries. There was a complete technology blockade over there. So as a result of that, they've now recognized that you need to invest in primary health care. Now, Infosys Foundation has given our PHFI money to train people in masters in public health, but co-locate them with NGOs who have got a community function, Community Connect. And during the course of their master's program, and 2 years later after the master's program, the foundation grants enables these newly trained public health functionaries and professionals to work closely with community-based organizations to bring about change. And we know that even during COVID, Deloitte, with technical support from PHFI, worked with the government of Haryana to empower frontline health workers to provide initial care as well as connect them to telehealth services being provided by nearby medical colleges. So we need to bring in all of these capacities together. And let me just conclude by saying, we do need to invest in hospitals, and that is where most of the CSR has been going in the past. But the government invests as well. But investing only in hospitals is like paying a compound interest on a bad loan. You'll keep on paying it. Unless you invest in primary care and public health, you are not going to be preventing the deluge of illness that is going to cascade into and around hospitals. So we need to do that, and we need to identify all the opportunities that lie in primary care and invest appropriately in leveraging those opportunities and addressing the right kind of needs.
Thank you, Dr. Reddy. I think the call to primary healthcare investment could not have been more clear. And I do hope that post the pandemic, we don't go back to the pre-COVID normal of ignoring healthcare. I think now there has been heightened investment in the sector, and it really needs to be mobilized more for system strengthening. On that note, I'd like to go to Dr. Arora, where ECHO model has really worked on strengthening systems, primary care, specific disease care, and widening the reach of healthcare overall. And Dr. Arora, it'll be great to hear your perspectives on this topic.
Well, thank you, Priya. And thank you to the organizers for this opportunity to speak here. You know, I live in the United States, where I've lived for more than 40 years now. And we have this project called Project ECHO, which currently operates in 190 countries. And our goal is to improve the lives of 1 billion people by December 31st of 2025. Now, in our work over the last 19 years, we've reached two major conclusions. One is, if you want to provide better healthcare to underserved people in the world, first, you have to strengthen primary care, or what you can call the last mile of healthcare. I think a second conclusion that we've reached is that we haven't found a single example of a nation anywhere in the world where care to the poor people has been provided by anything other than government. That means there is no philanthropic system large enough to really change the game. So if one wants to do things at a very high level, you have to strengthen the government. So the goal of ECHO is to enable governments to provide healthcare at speed, at scale, with higher quality, and at much lower cost. The way I would explain how we do that is through a small story of how ECHO evolved. I'm a gastroenterologist and I practice in Southwest US and New Mexico. And I've had a problem that there were 28,000 hepatitis C patients in our state. Only 1,500 had been treated. There was an 8-month wait to see me. So I was trying to say, how do I get treatment to all of them? Because people were coming to see me with cirrhosis of the liver and dying of liver cancers. And I knew how to do it, and we had the money, we had the medicines. And so I developed this model called ECHO based on the 4 ideas. First, to use technology to leverage expertise, one-to-many video conferencing. We developed in 2003. The second was to share best practices. So I went around the state of New Mexico and we set up 21 new centers of excellence for treating hepatitis C in rural settings, but run by primary care. But when I gave them my protocol, they were not comfortable treating. They said, this is too complicated. This was a treatment with medicines called interferon and complex. So the third principle was case-based learning. So I said, how did you become an expert? When I did my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another one present to my professor, and after 2 years, they started calling me a gastroenterologist. So I said I would use the same model to create new hepatitis C specialists in New Mexico. And the fourth principle is to track outcomes using the internet. So we deployed this model by weekly teleconferences where all 21 of these centers would join and present cases to each other and us at the university. And we did this week after week. And what we found is that in a year and a half, all of these people became experts in hepatitis C. The wait in my clinic fell from 8 months to 2 weeks. Over the next few years, we treated more than 10,000 patients. And we were able to demonstrate that we could get care to anyone in New Mexico who wanted it. Once we did this for hepatitis C, we then have deployed it for 70 different disease areas. It's a hub and spoke model. All the major universities in the United States have deployed ECHO. We partner extensively with the Indian government and so far have trained 3.2 million healthcare providers in 190 countries out of 650 hubs in 55 different countries. And during the COVID time, now I'll just mention 2 sentences about what we've worked in India. We had these railway tracks laid down across India in partnership with our government for TB and for mental health, etc. But when COVID came along, the government of India partnered with us and we have trained 770,000 healthcare professionals here over the last 3 years. But so much more work needs to be done. And I would really be honored to have the opportunity to partner with NATHEALTH to expand the ECHO project in India. Thank you.
Thank you, Dr. Arora. Moving on to Himanshu, I'd like to pick up an angle that we talked about less in the last few minutes, which is the financing side. And Himanshu, I know you all are working deeply in looking at healthcare innovations, but specifically funding of healthcare innovations through more innovative blended financing. So could you tell us a little more about this, and if CSR and other philanthropies can play a bigger role in more innovative financing, given we need more money for health, but we also need more health for the money. So would love to hear your thoughts on your work there.
Thanks. And thanks a lot, first of all, NatHealth, for inviting me here and placing me in between such stalwarts. And it's always difficult to speak on a panel, but definitely after the speakers before me, most of the points have been kind of covered. But you brought in a very important point of innovative financing, which, as you know, Samrit Healthcare Blended Finance Facility supported by USAID is trying to work on. And this facility actually came at the onset of COVID itself. We had been working in the innovative financing space prior to that also. But when the COVID wave struck us, there was a need felt that you need easy capital, affordable capital to be available for the healthcare industry so that they can scale up their operations quickly and take care of what is going to come in front of us from the pandemic. You rightly said that in the blended finance facility that we have established, we are looking at different types of capital. And what we are trying to do here is to blend philanthropic capital with commercial debt that's available and provide the social enterprises working in the healthcare space with affordable capital that they can use to scale up their operations. Now, the philanthropic capital is also of different colors, as the presentation by Mr. Rizwan as well as Anand showed earlier. It can be international donors, it can be HNIs, and it can be, most importantly, the CSR capital. We have been trying to kind of capture all the three areas, and while I would say that the large bilateral and philanthropic organization funding has been easier to come in, we have faced a lot of challenges when it comes to CSR and getting CSR to this kind of a pool or this kind of a platform. And I will kind of pinpoint a couple of reasons that we have kind of over the last year and a half come across that could be the reason behind that. If you look at CSR, there are two broad issues there. One is that CSR in the country largely has been mostly transactional rather than transformational. Most of the speakers before me emphasized this entire point itself, that it has to be transformational if we have to do something large, as well as the presentation that Mr. Rizwan did. Clearly pointed out the need that it has to be transformational, it has to be sustainable to have an impact. But if you look by and large, the transactions or the CSR funding that comes into the country in the healthcare space or other sectors as well is much more transactional in nature, is much more short-term in nature, mostly a year-long program. You put in the funding, you definitely have an impact on the ground to the lives of the people that you're directly working with. But that's not long lasting, that's not replicable, that's not scalable. As soon as the funding stops, that stops, that impact stops. Now, what is it required to make it kind of transformational and sustainable in the long run? And we have found that there are two ways of doing that. And one of the areas that Dr. Arora prior to me also mentioned, that working very, very closely with government. And in a country like India, where 900,000 crores is spent on healthcare annually, 20,000 crore total of CSR will also not an impact unless that CSR is used in a catalytical manner and working closely with the government to ensure that whatever projects the CSR is implementing gets scaled up in the government system. So that is one possible way of making projects sustainable. The second very important area is also working with the social enterprises. We have the Scale Up Innovation Hub that NatHealth is organizing right now. If you see the companies that are working there, they are all trying to bring affordable healthcare to the vulnerable population, be it in tier 2, tier 3 or rural areas. And that's where again CSR can play a very, very important role by providing that initial capital that these startups require to scale up their operations, to ensure that their proof of concepts that they have are commercially get validated on the ground and then can be scaled up whether directly or through government support. And that's where it becomes very, very critical that you have affordable capital available to them. And that's where facilities like Samrit come in to enable that. But we have seen that because of regulatory issues or lack of understanding about these new kinds of instruments, CSR has been kind of shying away from investing in these areas. And that's something I think, so if we have to make big changes using the small CSR pot of monies that we have, one would need to move towards these differentiated models. And happy to kind of understand that NATHEALTH is moving into that direction and creating another platform for getting together the CSR money, and really looking forward to how that shapes up.
Thank you, Himanshu. I think that's a nice segue to go into the role of NATHEALTH. Like you were mentioning, I think it's a great initiative to canvas and mobilize more CSR effectively. On that note, I'd hand over to my colleague Anant to walk us through this segment on NATHEALTH's role.
Thank you, thank you, Preeta, and it's awesome to hear such convergence among such a great group of people. Thanks for sharing your views. I'm recapping a few points Rizwan and all of you all made in terms of the barriers, and then I would pose in, starting with Professor Reddy and then people on the panel here, a rapid fire question on what is the call to action. It is important for us to think of what next, and the 4 barriers which came up in all your conversations. The first is, I think, Dr. Roy, you spoke about this. There is some degree of short-termism in the mindset. There is some degree of saying, agar maine operation kar diya to theek hai, but what is that long-term bet? The issue with long-term is one can't always see that metric immediately. It is not like providing a midday meal. It is something far longer term than that. There is a gap between your investment and gratification. So I think the first point is a metrics point. And I also go back to the big barrier we heard, that there is a sense of mistrust. So unless the metrics are clearly defined, this will remain. I think the second point I heard many panelists say is capacity building, enabling the, the front line. And this is sometimes also very critical, but something which is not done enough. The third point we heard was about pooling together capital. One of the challenges in pooling capital is you have to let go of ego, because moment you pool capital, you lose your name on the door. And it's actually a great thing for India, but sometimes not such an easy thing for many corporates to do. And I think the last point is blended. Thank you for bringing up the point, Himanshu. Leveraging a pool of capital, which is actually only 1% of the total spend of government, to actually act more like a catalyst rather than acting as the fuel. So with this in mind, if I can turn it over to Professor Reddy, what is the call to action of NATHEALTH? If you could wave a magic wand, what would that say? And over to you, sir, and then of course to the panel here, starting with Dr. Arora. Professor Reddy, go on.
Well, I think basically there is a consensus on the needs that we addressed, and I think there is also a consensus that we need to bring in all of the societal resources, particularly those available with the government and health systems, into play optimally. So what we need to do is to leverage the capacities and resources towards the ends that we have identified. So in terms of the actual NATHEALTH role, I believe NATHEALTH can serve as a motivator. It can also act as a scout to try and identify what are the possible valuable opportunities for support and select among them, to advise various contributing groups as to what might be the best areas to invest in terms of CSR resources, to be an enabler by building the right kind of partnerships, and finally acting as an independent assessor of how the actual programs have functioned, and then amplify that in terms of disseminating that knowledge. So let me summarize that again. Identifying the needs, opportunities to create impact with equity. Equity is a very important element. It can't be just impact in a niche area, and cannot be only confined to certain advantaged groups. Then identifying potential implementing partners and connecting them, and finding out who are the partners with presence in the area of intervention and the capacity to deliver. and to create impact monitoring and measurement indicators and processes. How do you actually measure the impact, and how do you monitor the progress? And finally, share the knowledge ultimately that has been accumulated and amplify the best practices. I think all of these are important roles that NatHealth can play in bringing the best out of CSR contributions.
Thank you so much, Professor Reddy. Dr. Arora, over to you.
No. An important role for NatHealth from my perspective would be, of course, collaborative philanthropy, because it's important to grow a few large oak trees than 500 tiny saplings, each of which will have less impact. I think a focus on capacity building at the last mile of healthcare is essential, not just for doctors, but not for nurses, not for physicians, assistants, or medical, but even for ASHA workers. The last, I think, capacity building with a gender equity focus is important. If you look at prevention in a family setting, who plays the most important role in that, in a family's health? It's the woman. And it's the women that have the greatest difficulty in accessing best practices because they are not fully empowered either financially. They often don't have agency. Often they don't have an ability to travel. So by bringing the workforce training and good healthcare best practices to the very last mile through capacity building has the ability to really produce equity in our country at all different levels and also enable the kinds of prevention forces we were talking about, good nutrition, good diet, blood pressure screening. You know, a woman at home can do many of these things if we were to enable them and train them. So I think that could be an important role for NatHealth.
That's inspiring. And both of you spoke of very tangible actions. And Dr. Rai, you spoke also of pooling the capital itself. Himanshu, love to get your thoughts.
Thanks, Anand. Besides the point that have already been mentioned, I feel NatHealth can play a very important role on two other areas. One, enabling government linkages for the CSR. Whichever focus area that NatHealth chooses to move forward with, it's very important that it becomes the bridge between the government and the corporates who are coming together, pooling their resources for that area, so that the priorities of the government are enabled through the CSR capital. And in medium to long term, government can take over those programs. The second important aspect, I think so, is on the regulatory side, be it the working closely with MCA or other bodies involved to ensure that CSR can be enabled and there is enough knowledge in the marketplace that CSR can be used for benefiting social enterprises or investing into social enterprises as well. Because while we, through our research, understand that that's possible, but we have found that corporates, because of the regulatory issues, because of the reporting issues and the accountability issues that MCA puts on them, shy away from taking risky bets where they feel that their investments can be challenged. And that's where I think the social enterprises kind of lose out on accessing CSR capital. So these two areas would be something I would say that NatHealth could definitely play a very active role in.
Thank you, Himanshu. Dr. Roy, over for you.
After Professor Reddy, Dr. Arora, Mr. Sikka, hardly anything left. But two things which I'd like to point out, what NatHealth can do. NatHealth, with the leadership it has, they have understanding of the delivering partner. Who are the people who will deliver, who can deliver. And they also they will have those who are funding will have a more dependability on organization like NatHealth. So NatHealth can be a bridge which knows the government, which knows the need on the ground, which knows who will deliver, who will not deliver, linking them up, and those who are the funders. So if that bridge will complete the CSR delivery and its impact in India and on our population. That's what they can do. Thank you.
Thank you. We heard the term bridge several times and building trust. Clearly some food for thought for Sunil and team as well. Bring us back together, sir. You heard a lot of thoughts.
Thank you. I think most of what needed to be said has been very loosely put across by all our panelists. Just to reiterate a few, I think NatHealth should scout for donors, help them deploy the funds in the right direction in the most needed areas. And very, very importantly, I think NatHealth should play a major role in vetting many of these funding and how it is deployed. Just to give you an example, I had a talk with a philanthropist who wanted to donate 10,000 dialysis machines to India. 10,000 dialysis machines. But our problem is not getting the machines. The problem is who's going to run it, who's personnel, consumables, so on and so forth. So there's no point in accepting that donation of 10,000 machines with no plans of how to deploy it. And I think that's where NatHealth and experts within NatHealth, I'm just talking about one program, but there are numerous other programs where it started with a bang and ended with a whimper. And I think our aim should be to get the donations, deploy it in the right direction, and make sure it is sustainable. It should not be a one-off phenomenon. That would be my recommendation to NatHealth.
Thank you. You brought it together brilliantly. Nothing thoughtless. There is clearly a long journey to go ahead. And maybe subsequent to this, it'll be great to bring together under NatHealth what are some of the short-term objectives. Really want to thank the panel on Preeta and my behalf. Thank you so much for hearing your thoughts, sharing your thoughts as well. Yeah.
Thank you, everyone.
So once again, on behalf of the organizers, many thanks to all our respected speakers present with us here physically and also joining us virtually. On behalf of you, we are going to be planting 10 trees at Roundtable, Maharashtra as our commitment and as our effort towards greening the environment. Thank you for your support and cooperation. Ladies and gentlemen, request you to remain seated. For now, we are going to be moving straight into the awards ceremony. Joining us shortly will be the Honorable Minister of Women and Child Development, Srimati Smriti Irani, who's going to be conferring the awards. And the awards ceremony, as she joins us, she's going to be with us close to half an hour. So requesting all of you to take your seats as soon as possible. Once again, if your mobiles are if you can put them on the silent mode, and we are ready to start the session with her. Ladies and gentlemen, would like to draw your attention. Let's give a hearty welcome as our chief guest of the awards ceremony joins us, Srimati Smriti Irani, the Honorable Minister for Women and Child Development. Thank you, ma'am, for joining us in this very important ceremony. As I would also like to request Mr. Ashutosh Raghuvanshi to please raise his morning, ma'am. Inviting Mr. Sunil Thakur and Mr. Shravan Subramaniam also to please join us. So our leadership team also present with us here on the dais. Ladies and gentlemen, welcome to all of you to NATHEALTH's first Healthcare CSR Awards. As we reward and recognize some very outstanding CSR projects which are making the right impact at the ground level. And towards that, not only improving the socio-economic health of the nation, but also contributing immensely towards nation building. We thank the Honorable Minister for sparing in time and joining us today. And I would now like to request Dr. Harsh Mahajan, the President NATHEALTH and the founder of Mahajan Imaging, to please welcome and introduce the Honorable Minister.
Thank you very much. It's indeed an honor for me, a privilege to welcome the chief guest today, Ms. Smriti Irani. And we all know her. We know how invaluable her contribution has been to this country in the last few years. She was elected to Rajya Sabha, the upper house of Indian Parliament, representing the state of Gujarat in the year 2011. In August 2017, she was re-elected to Rajya Sabha from the state of Gujarat. And in 2019, we know in the general elections, she was elected to Lok Sabha from Amethi after a historic victory. Mrs. Irani is currently the Union Minister for Women and Child Development. She was the Union Minister for Human Resource Development from May 2014 till July 2016, Minister for Information and Broadcasting from July 2017 to May 2018, and Minister for Textiles from July 2016 to July 2021, where I have personally interacted with her as Minister of Textiles. And if this country saw a revolution in the PPE kits, masks being manufactured indigenously, it is in large measure to her leadership. And that today it's a $1 billion industry and we actually export PPE kits to other parts of the world is testimony to her great leadership. She is India's youngest Union Cabinet Minister in the government and the first woman to hold office as Union Minister for Human Resource Development and Union Minister of Textiles. She has also launched Saksham, the first ever vision document released by any political organization in India, which underlines policies, programs, and implementation tools for the upliftment of the differently enabled in India. In 2019, at the young age of 43, she became the youngest cabinet minister. Apart from all her other skills that we know about, she is a fantastic orator, and apart from Hindi and English, speaks fluently in Bengali, Marathi, Gujarati, and Punjabi. She's also an author, having recently written a book of fiction called Lal Salam. I've read that book, and it's really worth reading. On a personal note, she's a very doting mother, a very gracious host, and a true friend. So, ladies and gentlemen, I present you Ms. Smriti Irani, Union Minister.
Morning, ladies and gentlemen. You may all be alerted that Dr. Harsh Mahajan has been more than kind in his introduction because he's my doctor. And whenever I see him, he has just one patent question for me. How are you still doing? And my response is, if something is broken, you shall know. So the man who puts me back together so that I can serve our country with diligence, you have my gratitude, sir. This morning I was to join all of you digitally to honor those who have shown leadership in one of the most challenging times in humanity. But as my doctor has prescribed and directed, he said, if you are able and willing, do join us physically. Breaking all norms, my doctor told me, as I sat next to him on an esteemed panel, you can take off your mask. And I reminded him that this is an adventure I cannot afford because it is a discipline that has been drilled into me by none less the Prime Minister of India and my doctor. But to live without fear, to live with a modicum of humility and gratitude, we are able to do so because of the COVID warriors and heroes that we see amongst us today in this August gathering and those who have joined us digitally. So at the onset, let me thank the entire healthcare force of India. It is because of your diligent service that we survived today. For that, you have our grateful thanks because you chose to serve when many were shutting doors, in the face of patients, in the face of needies. So I begin today my observations with a huge amount of gratitude, not only on my behalf, but every Indian who will join me in this endeavor. I am told that today there is an assimilation of some of the brightest minds in healthcare and medical history of our country. Those who serve us as administrative leaders in hospitals across the nation, those who invest in the healthcare systems of our country, those who do not have enough capacity to generate revenue, but who keep the engines of humanity going through their service as doctors, as nurses, and healthcare workers. As a woman, I'm prouder still of the fact that while we looked upon those who serve the healthcare systems during the pandemic, it is the 6.6 million Indian women as doctors, nurses, and grassroots healthcare workers who have gone door to door as ASHA workers, Anganwadi workers as well, to ensure that our healthcare systems are robust, irrespective of the challenges. Ladies and gentlemen, today as we gather to honor those who have also indulged in CSR activities, there are certain pertinent points with regard to the Prime Minister's endeavor towards strengthening healthcare systems in our country that I wanted to bring to light. As you all know, the recent union budget has enhanced the health budget by 16.5%. That today the government of India is committed to spending over 86,000 crore towards the healthcare systems of our country is a reflection of the resolve of the Honorable Prime Minister to ensure that healthcare systems in every district are robust enough so that we can stop migration for healthcare needs from our villages to our major towns and cities. One of the greatest and the most ambitious plans with regard to healthcare systems in our country was witnessed when the Honorable Prime Minister pronounced the Ayushman Bharat Yojana. Many the world over mocked us as to how will we serve the healthcare needs of our citizens in a country as diverse such as India, where linguistic skills, or for that matter, infrastructural challenges are aplenty. And that is why today It may be of interest to you that the Ayushman Bharat Yojana is functional currently in 33 states and union territories. Till now, the Government of India has issued over 17 crore 90 lakh health cards under the Ayushman Bharat Yojana. 3 crore 26 lakh Indians have found admissions in over 25,000 hospitals in the country under the Ayushman Bharat Yojana. And we've now seen that over those who are impaneled in hospitals, 42% are from the private sector. What may be of interest to you is that today, 3.8 lakh cases under the Ayushman Bharat Yojana are treatments that are given interstate. What also may fascinate you is that every second, 20 beneficiaries are identified under the Ayushman Bharat Yojana scheme. 27 hospital admissions are made under this scheme every minute, and every day close to 40 grievances are resolved by the government in participation with hospitals and private care health systems in this country under this ambitious program of the Government of India. While COVID threw up many challenges, we are taking a lot of solace in the fact that 50 lakh citizens received free testing support under this program of the Government of India. 90 lakh plus calls were attended to by the National Call Center, and 5 crore elderly citizens received benefits and support under the Ayushman Bharat Yojana. I've always looked at the female beneficiary list, ladies and gentlemen, given my disposition currently administratively, and I'm pleased to share with you that 47% of the beneficiaries under this scheme are women in our country. One of the greatest challenges and one aspect of research and reflection before the scheme came into being are challenges such as breast cancer and cervical cancer. This is a conversation I've had with Dr. Mahajan before. His institution was kind enough, in fact, to give free support to women, especially from economically challenged background, who wanted to screen themselves for breast cancer. And today I'm happy to share with you that there was a presumption that women, especially in the rural landscape, are unaware of the screening opportunities that can be given to them to support them through these various treatments. And I'm happy to share with you that only under the Ayushman Bharat Yojana, women, especially in rural India, we've had a cumulative screening for cancer with over 7 crore 20 lakh women benefiting only under this program. And today, under this program, with 1 lakh wellness centers in the country, we've seen a footfall of 45 crore plus only of women in such institutions. And while I say all of this, I look at the investor on the panel. These numbers are known to many who are administrating healthcare organizations. But to the investors, I say, the government is committed. We are hoping for a partnership from the private sector investment groups so that together we can serve the larger cause of a healthy India. Today, as Dr. Mahajan spoke about the PPE revolution, I must here share that when we saw a global lockdown, at that time India had never produced a single PPE kit indigenously. We did not have a single piece of machinery, nor did we have the raw material to produce PPE suits indigenously in our country. We had but one lab in Coimbatore which serviced the testing needs of the industry, that too of all that was imported into India. I still remember the month of March when there was a global lockdown, and especially when our country went into lockdown. An exasperated Harsh Mahajan called me and said, how will we manage to service the needs of our doctors and nurses? Because if we do not give them the PPE suits, we are bringing them to the doorstep of death. And I remember an exasperated doctor at 12 in the night talking about how will we find a solution. I assured him that there is a Prime Minister who is at work 24/7, and then you have a diligent patient who, if she does not make the PPE kits, knows that the doctor's services from her will be withdrawn. But, ladies and gentlemen, what I take a huge amount of pride in March, we did not have a single company producing PPE kits. By June, we had 1,100 companies. without a single rupee given in subsidy. We became the second largest exporters of PPE, suits and kits in the world in just 3 months. We reoriented our manufacturing capacities. We flew in a global lockdown, 30 to 100 machines from all over the world. This was the largest exercise and partnership that I personally had the privilege of witnessing, where the needs of the country were met by the intent and the contribution of the private sector and those in government. If we could do this in just 3 months, we can do much more. So here's to your tenacity, to your potential, to the talent that we celebrate on this platform today, with, again, my gratitude and my best wishes for your prosperity and for your service. Jai Hind.
Our sincere thanks and gratitude to Honorable Minister of Women and Child Development, Srimati Smriti Irani. We will now move to the award part of this function, and we are deeply grateful to the Honorable Minister for being present on this occasion, the first ever NATHEALTH annual CSR award ceremony. I'll just take a few seconds to explain what we are trying to accomplish here. NATHEALTH as a federation that represents the entire ecosystem of healthcare, starting from hospitals, labs, diagnostics, equipment manufacturers, payers, investors, service providers. We all came together and embarked on a mission, first of all, to identify the entire space, the healthcare CSR space, all the wonderful programs that are happening across the country. And during the pandemic, which has really gone and served those who are extremely, who were in the need of the hour at that time. What NATHEALTH, the objective, there are three-pronged objectives. One is to study the best practices that drive some of the best CSR programs, not only in India, but where the relevant examples could be found around the world. Second, NATHEALTH as a federation has been trying to drive some collaboration between the funders of CSR programs and the implementers of CSR programs on areas that are most critical for the nation. Third is, by virtue of its footprint and its partnership opportunities, NATHEALTH would like to work closely with both the central, the union, and the state governments to work on the most pressing challenges by providing a united front as far as CSR programs are concerned. The first step NATHEALTH did here was assemble a tremendously eminent panel of juries who understand this space very well. I would request Dr. Shyama Nagarajan, Managing Director, Sahamantran, to kindly come up to the stage, talk very briefly about the process that was taken to identify some of the best CSR practices in the country, and kindly introduce the jury who are present here. Thank you.
Namaskar everyone. Thank you very much, NATHEALTH. Sarve bhavantu sukhina, sarve santu niramaya. I think that was the intent with which we at NATHEALTH embarked on this journey of awarding the CSR winners. And the way we started, we adopted a very clear three-stage process wherein the CSR awards were evaluated as against 6 criteria of its relevance, its impact, affordability, its replicability, scalability, with a special focus on sustainability, and the intent of the organization's efforts. We started with 8 categories, and then we invited our eminent jury panel who is who in this country, known for their impeccable integrity and professional excellence. It's a proud privilege for me to introduce our jury members. Dr. R. Chandrasekhar, Chairman, IGBC Healthcare Rating, ex-Chief of Planning, Ministry of Health and Family Welfare, consultant to Indo-UK Institute of Health, consultant to World Bank, and visiting professor to South Bank University. Dr. Narottam Puri needs no introduction. All of us probably as children would have seen him on TV to make commentary on cricket, one of the eloquent doctors and ENT specialist, advisor, principal advisor to Quality Council of India, advisor to Fortis Healthcare, advisor to FICCI. Air Marshal Pavan Kapoor needs no introduction. Sir is currently the VC for Lincoln American University and played a very critical role today in the current war times to bring back our children from Ukraine and Russia. Thank you so much, sir. Sir has been the former Director General for Medical Services, one of the founder members of NABH, along with Dr. Puri. Major General Jagtar Singh, ex-Additional Director General Armed Forces of Medical Services. I don't think sir is around. I hope he's online. I'm not sure. Dr. Shankar Agrawal, ex-Director General, ex-Additional Secretary, Government of India. Dr. Sundar Rajan Srinivasa Gopalan, Lead Health Specialist of World Bank. He was leading the health practice for Sri Lanka. Dr. Santosh Matthew, Country Lead Public Policy and Finance at Bill and Melinda Gates Foundation. Sir has been a very senior IAS officer and worked very closely to bring about IT revolution in Bihar. These are our honorable panelists, jury panel, who made a tremendous effort painstakingly looking at each of the entry. We adopted a 3-stage process where we had earlier 46 nominations, ma'am, and out of which the jury member thoroughly evaluated each one of them and identified 9 panelists. And out of that 9 members, the members were made to make a presentation to our jury panel, and from that 4 were nominated. So I would now hand it over to Siddharth for taking over the awards for these members. Thank you so much.
Thank you so much. Thank you for that, Dr. Sharma. Thank you to all the eminent jury members. May we really present the video on all the nominations. A very short video. You can all see on screen the nominations, please. Now on. May I request the jury members to kindly come up to stage, please? And the Honorable Minister to kindly hand out the awards. It's my proud privilege. Please come up, please. Just kidding, please. Dr. Majan, please. Dr. Shyama, please come up to stage. Anesha, please come up to stage. It's our proud privilege to announce the third runner-up based on the short selection of the jury members. Please put your hands together for Deep Tech Medical Imaging Private Limited. The title of the CSR project is Deep Tech Gen-T Solution for Public Health Screening Using AI. May I request Ms. Ritika Taki and Mr. Amit Khanna to kindly come up to screen, please. Thank you. It's okay, please. The second run-up, it's our privilege to announce the second runner-up as Project Roshni by Roche Diagnostics India Limited. May I request Anju Vaishnava, Regulatory Affairs Lead, and Mr. Narendra Vade, MD Roche, to join virtually and kindly accept this award. Thank you. The first runner-up award goes to LPL Academy for Laboratory Medicine, Skill Development and Livelihood Generation in the area of healthcare by Dr. Lal Path Labs Limited. May I request Dr. Om Manchanda, MD Lal Path Labs, to kindly come up on stage, accept the award. Thank you. And for the champion award, the award goes to the project Total Health by Apollo Hospitals Group. May I request Ms. Sudha to kindly come up to the stage and accept this award on behalf of Apollo Hospitals, please. Thank you. Thank you to the jury members. I appreciate it. We have one more announcement to make today. And may I request Mr. Sunil Thakur to kindly come up to stage and make that announcement. NATHEALTH today is announcing its first curated industry CSR program, very exciting program, and I request Mr. Sunil Thakur to kindly talk about this program and invite on the stage the partners for this program, please. Thank you.
Thank you, Siddharth. Respected Madam Minister, distinguished participants, panelists, speakers, NATHEALTH members, friends from the industry and media, ladies and gentlemen. It's my privilege to talk about the first CSR program that's being launched by NATHEALTH. As we all know, India's COVID-19 vaccine coverage crossed about 183 crores. It was a daunting task, but we created this world record. In the process of creating this world record of reaching out to that many population, which could get us to 183 crore of vaccination, there were a lot of hurdles that came in the way, administrative hurdles in terms of, movement of vaccinations, but that got sorted out quickly. But on the ground, the one that we thought was the biggest hurdle was the awareness through which came about the hesitancy to take vaccination. And this was more prevalent in the far-flung areas. And that's the reason why we thought that awareness to remove hesitancy of, so it came about from, obviously from awareness and concerns about side effects, concerns about quality, distrust in terms of how it's going to get administered, expiries, all of that. And therefore, we felt to address this challenge, we need to collaborate with the right stakeholders to get to the bottom of, the bottom of the population base to create advocacy, to talk about what vaccine is all about, the benefits, to build that confidence within the population. Given that we learned a great deal, we thought this would be the best program for us to launch our CSR effort. And that's the purpose of launching this program, which we call as Win with Vaccines program. The objective of this initiative is to reach out to districts where vaccine hesitancy is high and coverage is very low. Specifically, the objective is to promote vaccine confidence among individuals and bust misinformation or myths around vaccines to accelerate the efforts of the last mile reach. Support government in vaccine drive and drive behavioral change and disseminate information around COVID appropriate behavior. We believe that a program like this will go a long way, not only in removing hesitancy for COVID-19 vaccine, but also any vaccine program that the government comes out with. We will be working very closely with the existing network, build new collaborations, use traditional and non-traditional media means to enable authentic information flow on vaccine efficacy, reiterating the message around the necessity of vaccination. We are privileged to partner with a few of our members, which is GE, Fresenius, and Chandrock Hospital. So with that, I would like to call upon some of our members who've participated in this drive. So Shravan, who's already on the stage. I would like to call upon Mr. Praveen Jain, who's Head of Regulatory Affairs, Quality and Government Affairs at Fresenius Medical Care. Prashant Sharma, who's MD, Chandrock Hospital. And then we have some of our participants joining virtually. Ms. Sandra D'Souza, who's CSR Lead, Wipro G. Neha Mujral, who's CSR Head and Legal Counsel GE, and Mr. Puneet Kohli, Managing Director, Fresenius. So they are joining us virtually. Can I request the AV to be played? With that, can I request Dr. Shravan Subramaniam, SVP NatHealth, President and CEO GE Healthcare India and South Asia, to come up and say a few words. More importantly, his motivation to join this program.
Thank you, Sunil. Just as we've had hesitancy in vaccination, there's also been hesitancy in CSR to support vaccination. And just as it took the first few bold steps to dispel that hesitancy in vaccination, I hope that many of our members will also join us and dispel the hesitancy in contributing to this vaccine hesitancy program. At Wipro GE, this has been a foundation of what we're doing to get our people back to work, and also a lot of our engineers who work in hospitals around the country. We wanted to make sure that they were safe and they were able to help our customers safely. So this was our motivation, and I really hope the entire NatHealth fraternity gets together to support this collectively. Thank you.
I'd like to take the opportunity to thank Ms. Smriti Irani, Honorable Minister, Women and Child Development. I know that the Parliament is in session, but you have taken this time, and we had promised 30 minutes to you. You have taken 35 or 40 minutes. But I am so grateful on behalf of entire NatHealth that you have come in person. You have increased the motivation for all of us to pursue this line, forge stronger partnership. And that by the time, next time we meet, you would see that there will be many more programs that are getting announced, and this is going to lead to a very positive impact. So I would like to thank you for this particular session. And of course, congratulations to all the award winners, the jury members without whom this would have not been possible, Dr. Shyama Nagarajan, as well as Mr. Anand Bhagwati from Bridgespan Group for having worked to make this a very structured program which can be replicable, and this can be scaled up pretty rapidly. I would like to thank for the NatHealth CSR program launch, Wipro GE, Fresenius, as well as Charnock, and for winning with vaccine campaign. And of course to the entire leadership team who is on stage here today. Thank you, Sunil, for curating this program, moderating this discussion. We'll take a 5 to 10 minutes break and we'll reassemble because once Honorable Minister has left for Parliament again. Thank you so much.
So once again, on behalf of everyone, we thank our Honorable Minister, Srimati Smriti Irani ji, for doing the honors and presenting the awards, the first NatHealth Healthcare CSR Awards, and also launching the NatHealth CSR Initiative, the Vaccine Hesitancy Campaign. Ladies and gentlemen, this award ceremony is going to be incomplete without thanking and expressing our deep gratitude and appreciation to our esteemed jury members. We have a small session now as we extend our gratitude and appreciation to our jury members, thanking them for the humongous task which they have done, each one of them casting very impressive footprints in their respective areas of work. We would like to hear from them also and thank them. I would like to invite once again Dr. Shama Nagarajan, the Managing Director of Saha Mantran Private Limited. Also inviting our jury members, Dr. R. Chandrasekhar, the Chairman of IGBC, Healthcare Rating, ex-Chief of the Planning Ministry of Health and Family Welfare, and consultant to the Indo-UK Institute of Health, consultant World Bank, and the visiting professor, London South Bank University. May I request Dr. Narottam Puri, Principal Advisor, Quality Council of India, Advisor Fortis Healthcare, Advisor Health Services, FICCI, Air Marshal Dr. Pavan Kapoor, VC Lincoln American University and the former Director General of the Medical Services, Indian Air Force, and one of the founder members of NABH. Major General Dr. Jagtar Singh. If I request our esteemed jury members who are present with us today here in the hall, request you to please take your seats. Requesting Dr. Sharma to please join. Dr. Sundarajan Srinivasan Gopalan, the lead health specialist, World Bank. He's going to be joining us virtually. Dr. Shankar Agarwal, the ex-additional secretary, Government of India, also joining us virtually. Dr. Santosh Mathew, the country lead, public policy and finance at Bill and Melinda Gates Foundation, and Dr. Narendra Saini, microbiologist, ex-general secretary, IMA. May I request you, ladies and gentlemen, before we call it a day here in this hall, the sessions, of course, are going to be happening in the other hall, continuing. We request for your utmost attention to this event. If I can request all of you to take your seats. We have our esteemed jury members already here on the stage. We would like to hear from them, their experiences. The evaluation process was shared with all of you. Now we hear from our jury members what has been their experiences of judging the various nominations which we have received and taking it to the four winners which we had, third runners-up, second, first, and finally the champion announced and presented award. So with that, can I just request people who are standing, please take your seats. Please be a part of this important session. And especially to all the awardees who've been recognized today, we owe a lot to our esteemed jury members for putting in so many hours and going through so many meetings towards selecting the winners. Please request you to take your seats. I think,
friends, hello. Friends, can I request you all to come and sit down for 5-10 minutes as we are felicitating our grand jury panel. Although Dr. Puri was saying why it is required, it's just all done. Why are we talking about this again? But then I would like to take this opportunity to invite our jury members who are here to actually help our NATHEALTH crew to understand that what are some of these criteria and how we looked at it, and probably serve as guidance to the forthcoming nominations in next year and onwards as what is that can be done. Because we looked at 8 categories, but when it came to giving awards, we clubbed all the categories because we didn't have enough nominations in all categories. And we chose finally the 4, but that did not mean that the other nominations were not there. So, but then what was lacking in those nominations? How and what? Maybe we could hear it from Dr. Puri, to begin with, sir.
Hello. Thank you, Shama. And good afternoon, everyone. Thank you, NatHealth, for inviting us over. From the perspective of what the jury looks at, the first great thing is that so many companies, so many NGOs, so many organizations are coming forward to do something for healthcare in the CSR field. And that's the first encouraging sign. Second thing is that whenever a new award is started by any organization, it will take its own gestational period before it finalizes into a set pattern. So the first year is always more difficult. Shama and team have done a wonderful job in trying to get 8, may I use the word, oldies together, who are very difficult to deal with in any case, and each one having an opinion widely divergent from the other one. So it's been a task, but the thing that warms the cockles of one's heart is the fact that people are coming forward to donate in the need in healthcare space being so large. And enough has been said in the morning session. I've learned a lot listening to the session that was conducted on CSR, Dr. Sudarshan Balal. And the important point I would like to just make here is that when you're deciding on CSR in health, my humble request to NatHealth and to you, Shama, would be that you don't get to pick subcategories in CSR. At this stage, it's just good enough to pick the best CSR. Let the organization decide what its strengths are in doing what it thinks it can do for the society at large. Therefore, subcategorizing within CSR is not the job of NatHealth to decide, but it should be the job of the organization that wants to do. And that will impose a greater challenge in the way you actually segmentalize or segregate the wheat from the chaff, so to say. And therefore, I would recommend going forward that you have a kind of a screening committee of NatHealth and yourself, which should look at whether the rules, regulations that you've laid down are conforming or not. And then only the chosen few should come to the jury. Because if you have more quantity to decide and it's very voluminous and time consuming, you usually find that something or the other gets left between the cracks. So those would be my humble suggestions. Thank you.
Thank you, sir. May I now ask Chandrasekhar sir to say a few words as to how the process could be made robust?
First of all, I'll congratulate NatHealth to take this initiative, and also Dr. Shama and team structuring it very well. Basically, while seeing it, we have also seen, like in the morning session, we heard that pre-hospital care should be the focus rather than, helping somebody for some surgery or some care. And that is where the sustainability, some of the entries were so fantastic. They have literally gone into the tribal area, and also the hemoglobin deficiency and what kind of a problem and the death happening and how this CSR is helping them to do it. Such things were very encouraging and nice to see the people doing this. Similarly, during the, children getting into cardiac problem, educating them. So while working out, some people were only focusing on improving infrastructure. So when it is scalability, resilient, even in the sustainability, these parameters are there, we could feel that yes, NatHealth should take note of, and in fact they should announce that the entries which are coming should have these kind of a background rather than, you know, just focusing a small or somebody supporting some hospital and getting it done. So that was the key factor which we thought. And you know, when the goals or the brief are set right, then the entries also will come to that extent. And that will be helpful. Even the jury will be able to take a appropriate decision. Thank you.
Thank you so much, sir. So may I ask Pawan sir to throw some light as to how do you think that when people are making their efforts, we realize that they were not presenting their efforts well. Would you like to say something on that?
Thank you, Shama. Good afternoon, everybody. I know the small amount of people who have kept here waiting for something to hear from us. I would like to add some value than what all my co-jury members, for whom I have a lot of regards, have already given some statements. But let me first compliment NatHealth for taking this initiative of recognizing CSR activities. This is the most important thing, that is the part of this event, was to recognize efforts towards CSR. That probably will serve as inspirational to others who will like to go ahead and, you know, come into the ambit of CSR activities. So first, my compliments to them. Secondly, my compliments to Anvesha, to Shama, to Siddharth for putting all this together and then selecting a jury who, of course, knew each other very well, but did not know that the other person is also there on the panel. Till that time, we actually did not meet virtually for the first session. And you know, the jury that we had, I am sure I learned from my co-jury members. I learned from those who presented those projects. Yes, some presented very well. Some could not present that well. They had a good project, but they could not present it to the satisfaction of some of the jury members. We did try to eliminate the presentation skills out of the overall impact of the project, but you know, it does in the long run make a difference in one mark here and there. Okay, so that does happen. Some of the good projects probably may have just missed out because of the presentation not being commensurate to what effort they've actually done on ground. So that could be one of the reasons, but I'm sure we all are quite mature enough to understand that we have tried to keep the presentation skills out of the subset for selection purposes, but maybe somewhere in the back of the mind, intuitively, could have been marked less. Nonetheless, I congratulate all the participants for participating in this initiative, for putting forward their activities, and for telling us that CSR is the way forward for this nation. In the morning session, we heard many things. I would like to ask NatHealth, what next? That question was asked. What next? Please connect the dots. Connecting the dots from primary to secondary to tertiary healthcare, that is important. You know, we are very proud of Ayushman Bharat. But you see the flip side, you see the other side, you see both sides of that. Is it going to be sustainable in the long run? How can it be made sustainable? It has to be through public-private people partnership. It cannot be without that partnership, and this is where CSR activities can focus on how to strengthen this system. We have people going to the hospital. I heard the other day there are only about 52% of the empaneled hospitals who are actively engaged in providing Ayushman Bharat care. There are many factors for it, why everybody else is not actively engaged. I also heard that 2% of the empaneled hospitals carry out almost 80% of the hospitalization. So when you get this data, and there are 40 crore missing population who are supposed to be beneficiaries, but they have not benefited out of this scheme. Why this has happened? Many factors. But what is missing is the linkages between primary, secondary, tertiary and quaternary healthcare. Somewhere we must focus on our CSR activities that will focus on those linkages between primary, secondary, tertiary and quaternary healthcare. A patient gets discharged from the hospital, Empanel Hospital. The follow-up should take place in the health and wellness centers, not in the hospital. That's where the linkages will begin. You heard about that eco project in the morning. You know, Indian Air Force is a beneficiary of that project. I have retired 5 years back. We conceptualized on the basis of eco I-REACH model, that is involving resource experts for augmenting community health. That was for capacity building. The only project that has outlasted me is this model in the Air Force. So we need to think about those issues and bring in CSR activities in these areas, which can help us to build capacities and to improve and increase and augment the interconnectedness between primary, secondary and tertiary healthcare. I think that's all I have to say. Thank you very much. Jai Hind. And of course, special thanks to Dr. Narottam Puri and Dr. Chandrasekhar, because whenever they are on a panel, rest assured, everybody goes back educated. Thank you very much. Jai Hind.
Thank you so much, sir. May I now hand over to the MC to felicitate our esteemed jury panel. Thank you.
Thank you to our esteemed jury members for doing this humongous task of selecting the winners, for educating us here, and also for your very constructive submissions and suggestions. Thank you. I would now like to request Mr. Shravan Subramaniam, the Vice President NATHEALTH, Senior Vice President NATHEALTH, to kindly present a token of our gratitude, appreciation to our jury members. And please, ladies and gentlemen, join us as we extend this thank you and gratitude. Thanking Air Marshal Dr. Pavan Kapoor, VC Lincoln American University and the former Director General of Medical Services, Indian Air Force. Thanking Dr. Narottam Puri, Principal Advisor, Quality Council of India, Advisor Fortis Healthcare and Advisor Health Services, FICCI. An appreciation, thank you to Dr. R. Chandrasekhar, Chairman IGVC Healthcare Rating, ex-Chief of the Planning Ministry of Health and Family Welfare. And also a very special thanks to Dr. Shama Nagarajan, who in fact was involved in this entire process, aggregator, bringing all the jury members together and facilitating this. Thank you. We'll close with a group photograph of all of you. So with that, ladies and gentlemen, we have come almost to the end of the day two here. And as we wrap up for the words of thanks to everyone, would like to invite Mr. Siddharth Bhattacharya, the Secretary General of NATHEALTH.
So it's my privilege to offer a formal vote of thanks and my concluding remarks for this wonderful summit. It's been a terrific 2 days. True to our theme of rebuilding, restructuring, reimagining resilient healthcare systems in India in a post-pandemic era, we have managed in discussions about building systems which take equity, access from words to action, an essential role that healthcare financing and delivery will play in achieving universal healthcare coverage. We have discovered and rediscovered how digital is the way forward and how it is the need of the hour to reorganize supply chains through digital adoption and value-based procurement. We have had insightful discussions, connections, conversations about the role of CSR in the healthcare in the country, and we'll have similarly about the advent of home care and of value-based procurement. We have also been able to successfully launch 5 cornerstone pivotal studies, one each in the areas which are linked to one healthcare continuum, which is home care, value-based procurement, which over time will shift the conversation from pure cost to a function of outcome and cost, which is real value from a patient-centered outcomes perspective. We touched upon the issue of embedded taxes and how it's leading to market distortions and inefficiencies in the value chain of healthcare. We talked a lot about, we released a vision document on digital health, and there's a lot of conversation around adopting digital health technologies, and particularly the ABDM, which will define the footprint and the architecture of digital health in India. It's very important that we recognize digital health as not an optional or an opportunity. It really is a must-do for the sector, because the way the consumers and our beneficiaries will choose to transact with the healthcare system is shifting very fast. Just look at our children at home during COVID and how the shift has really happened towards digital. And it's a force that's time has come. This pandemic has accelerated that transition probably by decades. Let me start by expressing my gratitude for the immensely kind participation we have had from government, led by Shri M. Venkaiah Naidu, Honorable Vice President of India, Government of India, Honorable Srimati Smriti Irani, Minister of Women and Child Development, for gracing us just now with her presence, Shri Amitabh Kantji, CEO, Niti Aayog, Dr. V.K. Paul, Honorable Member Health, Niti Aayog, Dr. R.S. Sharma, CEO, NHA, Dr. Praveen Gedam, Additional CEO, NHA, Mr. Deepak Bagla, Managing Director and CEO, Invest India, for sharing their thought leadership with us and reinforcing their strong commitment to build bridges with private sector. I would also like to thank Shri Rajesh Bhushan Ji, Secretary, Ministry of Health and Family Welfare, Srimati S. Aparna, Secretary, Department of Pharmaceuticals, Shri C.K. Mishra, former Secretary, Ministry of Environment, Forest and Climate Change, and Ministry of Health and Family Welfare, and other government dignitaries and senior officials for their support in this endeavor through their presence. We are immensely indebted to all the industry leaders who joined us from across the spectrum of the healthcare space in India. This is truly an innovative effort where we have tried to blend physical and digital means into one, and we have learned from it. If there are some areas or some glitches, we hope to learn and rectify it and have a more seamless performance in the year ahead. We would like to thank Dr. Pratap C. Reddy, Founder, President, NATHEALTH, Founder Chairman, Apollo Hospitals, for their support, for his kind support with this summit, and also being the light from which NATHEALTH took birth and draws inspiration. A special thanks must be reserved for the visionaries of NATHEALTH, past presidents, the NATHEALTH leadership team, led by Dr. Harsh Mahajan, President, NATHEALTH, Founder and Chief Radiologist, Mahajan Imaging, Dr. Shravan Subramaniam, Senior Vice President, NATHEALTH, President and CEO, GE Healthcare India and South Asia and Managing Director, Wipro GE Healthcare Limited, Dr. Ashutosh Raghuvangshi, Vice President, NATHEALTH, Managing Director and CEO, Fortis Healthcare, Ms. Amira Shah, Secretary, NATHEALTH, Managing Director, Metropolis Healthcare, and Mr. Sunil Thakur, Treasurer, NATHEALTH, Partner, Quadria Capital. I'd also like to thank the entire NATHEALTH Governing Council, the leaders from the functional forums, the leaders from the regional forums of NatHealth, as well as the general body of NatHealth for their wholehearted support and participation in the 8th NatHealth Annual Summit. I see the reflection of each of you in NatHealth, and it's difficult pulling an event of this magnitude without your constant support, leadership, and commitment. Now I must thank those without whose generous support, both monetary and morally, this summit would not have been made possible. Our summit sponsors, our gold sponsors, Acumentis Healthcare Private Limited, Apollo Hospitals, Dr. Lal Path Labs, Fortis, and HCL Healthcare. Our silver sponsors, Johnson & Johnson Private Limited, Mahajan Imaging Private Limited, Metropolis Healthcare, PD Hinduja Hospital, Philips Polymedicure Limited, Roche, Siemens Healthcare Limited, Vigan India Private Limited, and Wipro G Healthcare Private Limited for carrying us forward throughout this summit. Our session sponsors, led by BPL Medical Technologies, Healthium, Medica Hospitals, Medtronic, Neotia, Getwell Healthcare Center, ProTribe, Terumo India Private Limited, and Wokhart for their immense support. Young organizations like NatHealth are able to go the distance only through the support of such believers. Our true friends, the ones who drove this summit which are our valued partners, they deserve a special round of applause. Our summit concept partner, Arthur D. Little, our knowledge partners, Access Health International, PwC, Arthur D. Little, ICWA, the Bridgespan Group, Sahamantran. Our core partners, TIE, our event management partners, India Attitude, our communication partners, AVNWE, and our media partner, Health Biz Insight, and BWTV. We have pulled off something together, which is remarkable, and something we should all be really proud of. I'd also like to thank Mr. Karan Singh from Bain and Company and his entire team, without which, who has been a key contributor to the forward strategy and the agenda of NatHealth 3.0, many of whose tenets were visible in this summit. Next, I must express my gratitude to our incredible line of speakers, moderators, and panelists who have carried to fruition the mission of this summit, which was to create a forum for meaningful dialogue that will help us lead the convergence of different stakeholders in the industry. It is your contribution to this mission, to this summit's discussion, which we hope will open doors of collaboration and newer horizon for the industry in the near future. The same thanks is to be extended to our CSR jury, who dedicated their precious time and energies into forging a new CSR alliance. The Business Opportunity Pavilion and the Startup Session participants have similarly helped us illustrate another core theme of this year's summit deliberations. These players are leading innovators in the Indian healthcare ecosystem, and they're leaders who are transforming dreams to reality. As we consider ourselves immensely lucky that they chose to share their projects and insights with us, we thank all our nominees for the CSR awards and congratulate the winners. I must now thank the names and faces who have worked tirelessly to build this event with their own hands and often at the cost of their night's sleep. The NatHealth Secretariat, Ms. Annesha Pandey, Deputy Director, Brinda Chaturvedi, Project, Chapter Lead and Forum Coordinator, and Ms. Anugrah William, a Government Partnership Specialist and Northern Region Chapter Lead. I thank my entire team, all three of you, from the bottom of my heart. All of them have fought through rough, long days and even illness to make this summit happen. The ADL team, led by Barnik, Fabian, Prithvish, Saloni and Mukul, Jayata and the Health Biz Insights team, the India Attitude team, led by Bhanu, Srasti, Shubhang and Amit, the AVN team, Manas, Julia, Samiksha and Gulshin. The event exists because of your hard work. I would like to thank our MCs, Vimi Chaudhary and RJ Adi, whose subscriber base has held this event together. My immense gratitude in the delegates who joined us both physically and virtually, We were a bit worried about being over-ambitious with the idea of taking this summit phygital, but the outpouring of delegates on both formats, over 1,000 delegates, have us more than satisfied. Thank you, all the delegates, for tuning in and listening. We also hope you will consider providing us with feedback on the summit and continuing to be a part of the NATHEALTH 3.0 community. Finally, I thank our venue partners, the Lee Meridian Group and the JW Marriott Group. Your physical spaces have allowed us to create a space like NATHEALTH. Thank you all for making this summit a huge success it was. If this brings us to the conclusion of this summit, in the other hall right now, startup pitch sessions are still going on. We have about half an hour between now and lunch. If some of you would like to go spend a few minutes with the startup, encourage them, I wish you everybody the very best. Please tune in and join us after the lunch for two interesting roundtables that will happen. One is going to be on home care, for which the paper was released by Dr. Paul, and followed by a roundtable on value-based procurement, which will happen in this hall. This paper was released by DOP Secretary Ms. Aparna yesterday. I wish everybody a very happy and a prosperous Navratri ahead. And I hope for those of you who have joined us from outstations, wish you a very safe and happy travel back. Thank you, everybody. Thank you for joining us today.
Thank you, sir, and thanking once again all the eminent guest speakers, all the participants, delegates. Ladies and gentlemen, we close here. 1 o'clock, the lunch will be served. Meanwhile, as was mentioned, we have the sessions which are on in the next hall. Post-lunch, we have 2 roundtables, so also we are requesting you to be part of that. Thank you once again for joining us. Jai Hind.
a couple of excellent sessions, very interactive on parts of the continuum of care we've not looked at. A lot of discussion on that yesterday. And as we saw, even Dr. Paul being a big proponent of if we were to deliver care, a lot of this care has to be delivered outside the hospital. And so we have this roundtable on home health care, something which came really into the forefront during the pandemic. I'll ask all the panelists to actually come on stage. Meena, Dr. Samir Gupta, Amitabh Jain, Rishabh, Dr. Mahesh Joshi, Vivek. So I think we'd start off with a small presentation by Vivek and Mr. Rajiv on some of the tenets of the paper. What are some of those highlights? What are some of those components which went into that? And I think that'll serve as basically a template to the discussion as we go ahead. Over to you, Vivek.
Hello. Hello, good afternoon everyone. Just to put the context of the paper, we, all the home healthcare players have come together and started an association. And one of the first things which we did after starting the association was engage with NATHEALTH and PwC to come up with a paper on Indian home healthcare, which got, inaugurated yesterday. What I'll do is I'll just quickly cover some salient features and recommendations of the papers primarily. I think the paper was available yesterday and I'm sure it will be available today for people to read through in details. But I think the objective of the paper was to determine that home healthcare is a big part of the healthcare industry. It will create a lot of impact in the future. It has created a lot of impact historically as well, and during COVID times, more so. Though largely has been unorganized till now, we are trying to make it more organized and see how can we create a larger impact in the agenda of the healthcare in the country, because we all know that we can't solve all the problems through the hospitals. And Indian healthcare requires more innovative solutions, and home healthcare and out of hospital is one of the biggest solutions which can handle the infrastructure deficit in the country. So I think these are some numbers. I'll not flip through them. There's there in the paper. But what I'll do is we had come up with a proposed recommendation set, and I'll directly jump to a summary slide of the recommendation set and talk about the recommendations from this. So basically, if you see, we divided the recommendations, which are 14 recommendations, into 4 buckets, and I'll talk about the big bets in that, right? So the big bets are that if we can get the registration and licensing of home care providers, that basically sets the clinical context. Otherwise, home care is considered staffing or almost a maid plus kind of thing because of the large unorganized player. But if we have to create the impact and clinical outcomes, that is one of the biggest things. The other thing is that how can we get financing into it? One of the challenges which we see in home care is that while hospital care is largely financed through insurance or government schemes, these are some things which are home care is not particularly covered in any of these schemes, and that, if done, could actually lead to a significant improvement in the clinical outcomes of the country and lowering the cost. We all know that home care is much cheaper than what you will be spending in the hospital, but because it's not paid up, people typically are spending a lot of time inside the hospitals. If we are able to create space for more innovations in this by technology and otherwise. That's one more recommendation which you have given, and the paper talks about more details into it. I'll not spend more time in specifically talking to each and everything. And the other thing in the big bets is about capacity building. So, addition of home healthcare providers as a recognized set and putting investment in their training, recognizing the skill set, because that's where the standardization will come into picture, right? And then, some of the easy wins, easy gains are basically having an accreditation standard. So QAI, which is a body which has set up the first accreditation standards for home care in the country. If you are able to, if the government is able to recognize it as the standard, then it becomes it basically gives the payers and the consumers a way to differentiate between people who are in the unorganized space or may not be able to deliver the good quality versus other players. So I think those are the key recommendations I thought are important for us to put our minds together. Just repeating: one, financing, very important; second, standardization; and third, just building capability. I'll just stop here and hand it over to Rajiv.
Thank you, Vivek, and good afternoon, everybody. So Vivek has covered quite comprehensively, in a very succinct manner, the whole scope of home health care and where it fits in, what might be the way forward, and what are some of the imperatives and critical success factors for it to become a tremendous value add in terms of leveraging healthcare for all in this country. So I will just touch upon a few other points where Pricewaterhouse and NATHEALTH and this report have done an excellent analysis of what might be the scope of leveraging home healthcare quite imminently. So a large number of reports are available. People know that the home healthcare industry is wide and large, but there is a sort of a value unlock model that has been created by Pricewaterhouse in the report, and I would urge that if you all can get a hold of this report, please do read. It's very in-depth and very informative. So there are three legs of the stool on which this whole sort of value unlock is predicated upon. The first being digital. And a lot has been talked about that. And we've also seen that, especially during the pandemic, where digital provided a strategic leverage and advantage in covering the mass of people that required care at that point in time, and where the current infrastructure was unable to cope with it. Now, we've talked about it, we all know about it. If you have 20 lakh hospital beds in the country, there are only 1 lakh ICU beds in this vast country of ours. And it was so much more pronounced when the pandemic, the second wave hit. And I think the adoption of digital health got a strong fillip during that period. And we see a lot of scope in that, in leveraging it even further. It will provide scalability and consistency in terms of the quality that can be delivered. The other is the scope unlock. And here again, whilst the organized sector, and again this is articulated in the report, the organized sector of home health care constitutes less than 2% of the total home health care market, right? So there is a wide scope for growth. Apart from growth, the type of services that have been, over the last 3 years, that have been delivered in the marketplace have covered a lot of ground in terms of what was being done in a hospital setting earlier. So therefore, it forms an excellent piece of continuum with the overall healthcare model and the value chain that we have in the country. So, and there is, and I must say this, even though I belong to the industry, that there are some very, very competent people, very, very competent companies that are actually driving the home healthcare market today. And therefore, it's only our imagination which can limit the scope that we can address. And finally, the other third leg of the stool in terms of value unlock is the geographic unlock. And again, we hear about this, that we need to have healthcare more penetrative, we need to have deeper into the country, quality healthcare that we can deliver. And here again, if you look at home healthcare, the way it is maturing, the way it has matured, and the way it is maturing, and superimposed with a digital model, I think the whole penetration in terms of geographies can be really far and wide. The report, of course, talks about some of the smart cities, which is target number 1 and low-hanging fruit, but it's beyond that. And I think, as in yesterday's session, my colleague Vivek Srivastava had said, how this can be a value add to the government in terms of enhancing the scope of healthcare that is being delivered in the country. So, in summary, essentially, once you've gone through this report, one needs to not only adopt, but embrace care at home, because it has a lot of potential that we can leverage right now. So with that, I will leave it to the panel now to take the discussion forward. Thank you.
Thank you, Vivek. Thank you, Rajiv, for putting an excellent context. I think we have all the ingredients in our country to bring home healthcare to the inflection point. But I think the whole component of how do we really build an ecosystem. We are also honored to have Dr. Naveen Dang and Dr. Madan Gopal join us. This is both a physical, welcome Dr. Madan Gopal, Dr. Naveen Dang. Pleasure having you on board. I'll go to Dr. Madan Gopal, and yesterday we did have Dr. Vinod Paul, and one of the most emphatic component was, while we're looking at home health care, more from a private sector component, how can home health care actually be integrated into the primary care healthcare network? How can we build and standardize that? So that was a very interesting insight he brought in. And I'll ask Dr. Madan Gopal about, what are some of those thoughts as we build it? Because we don't want to build a private public, we want to build something together which will benefit every Indian. Dr. Madan Gopal.
Okay, thank you, Dr. Rana. To continue where in coming days it is going to increase and increase and increase. If you look at the structure in which the public health system, if you look at how the public health system is structured, right from a district hospital, then you are having a community health center, then you are having primary health center, then some health centers, and there are extension of services through the ANs and your ASHA workers. That extension is there. That means they are already going to the home, doing home visits and providing treatment or extension of services, whatever the package of services are presently there. They are providing presently focuses on maternal and child health, and this can be extended to include other services as well. They are only giving up services on a contact basis. That means they are just going there, contacting the person and providing the package of services. They are there in the government system.
Second thing which has evolved during this pandemic times is the home care management of the patients. It has popularized the home care concept. Otherwise, it was only restricted to the urban areas, mainly the physiotherapy and the home care collection of the samples and home care setting up of the ICUs. That was only restricted to the metros and that kind of place. Now this home care has now percolated down to tier 2, tier 3, as well as down to the village level also. Now that kind of popularity is there. Second important aspect, which is the changing demographic pattern which we are going to witness. The senior care, as
you are aware that seniors are also increasing. That means from 8% in this census, it would be 12%, or we are expecting that it would be around that thing. And in the coming days, it's going to increase. And if you look at the demographic pattern of the seniors, 93% they were in the unorganized sector and they would be in the rural areas. And they have to be provided some package of services or treatment. Then and there at their place, near their place only. You have to see that how we cater to this population. There's a challenge, and this home care is it's an upcoming thing, and we will see that how we extend its services to them. It's only not restricting to OPD care or other care. This beyond that, there are many determinants which are there.
I think during the presentation
Making when we have made that presentation before the finalization of the report, other aspects are also coming up as more and more home care engagement is happening. There are other aspects are also coming in, not to undermine the aspect of the quality of care. There are other aspects, the other social factors are also coming forward. There are harassment issues of the providers as well as the recipients. Nevertheless, there have been push for this home care, and we see that how this home care can be recognized. There have been a struggle going on that you have to see that this home care can be equated as a hospital care, and we see that how we move in that direction, and because that will require change in the definition of the hospitals and the Establishment Act. And we are trying to see that there have been representation from the industry bodies, and we are seeing that how we move in that direction. Panaji, I will stop here. I will be willing to take more questions at this point. Thank you.
No, thank you, Dr. Madan Gopal. And I think one of the best things we've seen is it's both the private and public sector coming together and building the home care ecosystem together. I'll next go to Dr. Dang. And Dr. Dang, I think when you look at home, I think the first point of access is, of course, the diagnostic players. And there was no better time than the pandemic. We saw that there was an outreach to each and every household. How do you see the role of diagnostics in the home health care play just beyond sample collection as this industry evolves?
Thank you, Dr. Mehta. I was expecting and waiting for this question because the whole scenario of my very existence has changed over the last 2 years. I always felt that was the touch and feel of the lab, touch and feel of the patient walking in, and the samples being collected out here, and the total visibility and transparency where they could see how the tests were being performed was available. But the pandemic changed everything. Even till now, 2 years on to the pandemic, patients are extremely reluctant to come to the labs. There was a time before the pandemic when there was 90% walk-in patients into my lab. But now it's the other way around. 90% are home collection and only 10% of patients who are walking in. So that concept of a brick and mortar structure has totally changed. Now we are being represented by our lab technicians and phlebotomists who go to collect the sample. So it is no more Dr. Dang who is there to hold the hand. There's no more Dr. Dang to give solace to the patient. So the whole concept has changed to home collection, but like what you said, what is there beyond sample collection? Beyond sample collection is training. Training of the person who's going to collect the sample. Training of the people who are going to give the same kind of solace and empathy to the patients which was being given by me or my team before. And second thing is now there was a time when all the patients were coming and asking us for the interpretation of reports. The interpretation of reports also has totally changed. First, there were only 2 people maybe handling the patients and telling them what was wrong or what needed to be further examined by the physicians. But now here again, now we've got a whole set of doctors sitting out here to answer the patient questions. Patients are happy. And I can say to some extent, we are happy because we have to change with the times. If we don't change with the times, we perish. Before I came to the session, why I was slightly delayed was that I was in the pitch session for the new startups which are coming up. And it was very interesting to see that a large number of startups are basing everything on artificial intelligence. I was immensely pleased to see that there's an app coming up for, say, diagnosis of autism. Just on the basis of that app, and seeing how the child is behaving with the physician, they're able to diagnose with nearly 99% certainty the diagnosis of the patient. Similarly, there's so many things which are happening which are going to take us forward towards home care becoming more and more important, more and more, I'll say, economically viable also. Because please remember, may it be a small village or may it be a large city, there's a major concern about going to the healthcare provider. May it be a hospital, may it be a dispensary, may it be a doctor. Now everything can be done through the digital mode, through the virtual mode. Number 3, after this, like what Dr. Madan Gopal said very nicely, is the demographic pattern. The number of senior citizens are going on increasing. The ability to go to the physician, etc., to go to the healthcare providers is also getting limited. So we'll have to evolve a system where home care gains more and more importance. I will not forget those days when we were much younger, that there was a concept of a family physician. A physician would visit the home, look after the patient, ask for certain kind of tests. Well, actually there were no tests available those times, and then just by examining the patient, give the diagnosis. I'll maybe say something out of the box, which may not be liked by many people. I do not like the concept of the doctors relying too much on lab reports and radiology findings. That very concept, like what I call, which has come up, is hyposcalemia. That is lack of clinical skills. The importance in the medical colleges is now being given more on interpretation of reports than examining a patient. Maybe the concept of general physicians, maybe the concept of family physician will come back, where a doctor will have to go and visit and provide home care to the patients at their own doorsteps. And that is what is required, and that is what is needed. And along with that, with new technologies coming up, with point-of-care testing systems, which are being manufactured and, I can say, visualized by different diagnostic companies, which can be carried by the doctor themselves, or the patient themselves be trained to test themselves and provide those reports with a certain kind of accuracy to the physicians, again will play a major role. When we at the moment are saying that the number of COVID cases have gone down significantly, but are we actually getting the true numbers? Because if you see, large number of patients are doing home testing, and those tests are not being reported. But on the other hand, look at the convenience to the patient. If the patient is sensible enough, they're doing the tests enough themselves, and with this Omicron variant, where not much intervention is required, they are themselves isolating, and we are seeing every day that the hospitalization is decreasing. That means the patients are though testing positive, but still they themselves are being responsible enough to see that the disease is not being spread. So all these factors deeply convey the fact that home care testing or home care is something which is the future and which will be economically viable, which will be patient friendly, where both the public and private sectors both will be able to work hand in hand together and give the best to the patients possible.
Thank you, Dr. Nang, and I think very encouraging that both accessibility, affordability will go up with home care, because evidently getting to the providers is always difficult. Meena, I'll come to you next. I think if you look at this whole healthcare ecosystem and what you're trying to put, it's probably one of the most complex, because you're trying to get the providers, you're trying to get the payers, you're getting the med tech, you're getting the digital players. You're all putting them together, and traditionally they've not worked with each other. So one, we spoke about, Vivek and Rajiv spoke about the potential, but how would you really catalyze this? What are in your points as some of the building blocks we need to put in to make sure that if we were to come back to this conference 5 years later, we'd say, you know, wow, home care did better than we really anticipated?
Thank you. That's a tough question that you've given me, to look into the future and say what we need to do now to get to that beautiful, shiny future. So in my view, there are a few very, very key things that need to happen. What has happened willy-nilly over the last 2 years is the consumer preference. Otherwise, I would have put that first, saying people need to be willing to take care at home. But for whatever reason, and helped by COVID tailwinds, this has changed. So the consumer preference very clearly for using digital as well as care at home has transformed pretty significantly. So in that backdrop, now is an opportunity for us to look at all the key pieces. How do we make sure that the different pieces of the healthcare providing ecosystem, that is the labs, the hospitals, the home care players, all of us come together to agree how does this whole thing work? What is the standard treatment guideline? What things should be done in the hospital? What should be done at home? At what point do you discharge from hospital? At what point do you discharge from the home care? What things are ideally better done at home than sending people to a hospital? So that agreement and understanding across the different parts of the ecosystem is probably one of the most difficult things and will take years to happen. But I believe that is essential, because then that gives clarity to the other parts of the ecosystem. Then you know, the payers know what they should be paying for, in which place of the whole food chain. Should they pay for hospital care? Should they pay for at-home care? Should they stop paying for something because that seems like just supportive care? How do you make that happen? So once you define that, then you're able to determine how the paying happens. And then the third piece to me is, of course, how the government supports all of this. Because obviously we are seeing good conversations with some of the payers, but they're all private payers who understand that quickly and are able to jump in and start to incorporate packages which are both a combination of hospital and home, or at home only, or at hospital only. They're able to see this whole food chain and are able to put it in the right place. But that's still a very small part of the payer ecosystem, as I'm sure you know better than me. So we do need to get understanding from the government and the various public sector insurers, getting them on board. And I'm very grateful to Dr. Paul and Dr. Madan Gopal to showing a lot of enthusiasm and also showing us some direction. And the fourth piece, which to me is very interesting transformation that I've seen in the last 8 years, is just the human resources piece. When we started home care, and I'm sure many of the other providers also on the panel would have realized it was very difficult to recruit people. Nobody wanted to work in home care. They always felt that their careers were better served if they work in a clinic or a hospital setup rather than in a being sent to patients' homes to care for elderly or for the sick or for really critical work also. But in the last 8 years, we have seen significant transformation, and again it's got a fillip during COVID, because some very, very complex procedures ended up being done at home, either because it was COVID care or because due to COVID, people with other conditions were not able to get to the hospital. So the staff have realized that this is a good career. You get really good opportunities to do high quality work, and while you get supervised, you're not micromanaged. So you do have an ability to bring in your own little bit of creativity or your own skills to the fore, rather than being told minute by what to do if you're in a hospital environment. And of course, they have seen growth, they have seen good compensation. All of this has helped create some brand for home care as a career. But still, the capacity of people that we need to deliver home care, especially for, as Dr. Madan Gopal said, a very large elderly population, just doesn't exist. There are a lot of people, a lot of unskilled manpower that goes and does a lot of these services, and that's not very helpful to the patient or to the industry. So we need some support in that as well, and I believe the paper is also touched upon that. So I do hope that we are able to make good progress on all these 4 dimensions, which perhaps if 5 years we are sitting here, we can look back and say, yes, it was a pivotal moment, it was a turning point in the growth of the industry, and the impact for patient care has been tremendous in this process.
No, thanks, Meena. I think the impact and making sure that, because one of the things which the pandemic did was bring healthcare as part of our national discourse. Mayank, it's great to have you back. And yesterday we spoke about, the payer in the continuum of care. But now if we were to very specific to healthcare, and you spoke about, what's insurable, what's not. How do you see the roadmap to the payer's role in the home healthcare ecosystem developing over the next 3 to 5 years?
Yeah, thanks, Chana, and it's great to be back today. I was just listening to what Meena was also talking, and in fact, I remember when we set up this organization 5 years back, we met and we were, we've been discussing since then that how do we bring home care, and I think Vivek also on the panel, and I remember many conversations around how we can bring this into the fold of insurance. Because firstly, from my perspective, home care is a reality. I mean, it's about how fast we make it and get into the mainstream versus whether and if at all it should happen. So so at one level, as a payer, I'm very much for home care, and it's kind of becoming a part of the mainstream, because I think it makes a lot of sense because of just an alternate delivery model, lower cost of delivery, consumer convenience, and so on and so forth. I mean, which I guess the experts can talk about more. But so as a payer, some of the challenges that we need to address is, I think, how do you start defining home care, right? Because at the end of the day, if a payer has to pay for some services, we must know that these are the kind of services that we may have to pay for, and therefore price into our products and also promise payment to our customers. So I think one of the areas that we have to work more and more and more, and I think that's, to my mind, that was the biggest reason why it has taken so much time, even though we had that intent, because it was very difficult to define. Is it separate? Is it an extension of the hospital, stay and impose that, or is it standalone? And because that will also define the way, even from a regulatory perspective, it will be approved, right? Because there is a clear definition today of what can be treated as hospitalization stay and what need not be. So I think that is one big aspect of I think work that needs to be done to define that, and that itself will be a great start, because we are definitely in fact in some of our products, especially senior citizen etc., we already have this benefit of home care treatment etc., because we've been able to define it more specifically for that segment of consumers. And the second thing I think is about constant dialogue, constant conversation, and also how can we jointly make consumer accept this as a real alternative to what they see as I'll go to the hospital, I know the quality and I've got comfort, and whether the consumer has that comfort that if I get home care, I'll get the quality treatment and I know who are the providers. I think just kind of creating more consumer awareness, consumer acceptance, consumer comfort. I think that also as a payer will help us, because today if we suppose I were to promote that go and take home care, I mean, we don't want to take any medical legal risk on our book, right? Because it's finally a consumer choice that they have to make. And but at the same time, if you are proposing something or in so-called promoting something, we must be very clear that who will deliver that, and if at our instance it is going to be delivered, it must meet the expectation of the consumer, because finally it's a very sensitive area. It's medical, and in this few things can go the other way around. And so we are as payers, and I can say for myself, for our organization for sure, but I know that based on our conversation in different parts of the ecosystem, that we'll be very happy to bring this, because ultimately it's business for us also, right? Because a larger part of the healthcare expenditure comes into insurance. We are now, I know our coverage will be much broader. So I think I'm, very, very positive about this. I'm very happy, for the, and I can say that on behalf of the payer category that we'll continue to work with the, the home healthcare, colleagues of ours and entities to bring this into mainstream, and including conversation with our regulator, because I think the regulator is also very open to bring this. It's just about finally solving a few open issues as of now.
Thanks, Mayank. And I think, I think the whole ecosystem working together and, making sure that there's a conducive regulatory environment, I'm sure will kickstart this. I'll go next to Dr. Sameer. I think one of the areas where there needs to be a much better coordination is obviously the provider and the home healthcare players. because a large segment of home health is post-operative care. And as we saw, sometimes you use the patient is after a time using the hospital as a hotel, which is not productive either for the hospital or for society because we lack beds. So how do you see this whole integrated play between the provider and the home health care developing?
No, I think this is a great question, and we also often struggle about this. But first of all, thank you for this excellent paper. I read this paper, and I think it's very useful and will help define how it's a great framework for how home healthcare is going to be in the next 5, 10, 15 years. Let me just tell you first how I look at home healthcare. I wear two hats. One is that of a medical administrator, but the other hat, which is my day job, is actually I'm a cardiologist, I'm a doctor. So, home healthcare, when I look at healthcare in general, there's preventive healthcare, and some of the panelists before me mentioned that, the ASHA workers going home. I remember when I was in medical college, I went and gave polio pulse vaccine at home. So that was kind of a very preliminary grassroots level home health care. Then there is primary care. Primary care is, I have a headache, I have a runny nose, I have a little bit bad throat. A lot of that is probably going to be digital going forward. If you want to get a blood test, you call someone, they come home, you can call Dr. Dang, you can get a blood test, you want to get a chest x-ray, you go to the diagnostic center, you get a chest x-ray, you come back, you share it with your doctor, and that is all done without going to a clinic, without going to a hospital per se. Then there is secondary care. Secondary care means, you have a little bit of an infection, you may need IV antibiotics for a day or two, you may need some IV fluids. That is where I see a lot of home health care coming in. That is where you're not really sick, you can be managed at home, you may be able to be treated at home. That's where I see the niche of really good home health care coming, because once you go tertiary care, where you need ICU, where you're sick, where there's a chance your blood pressure may drop, nobody really wants to be treated at home. You want to be in a hospital that if things go south, boom, you're taken immediately with 24-hour doctor, 24-hour nursing, the entire equipment and stuff over there. As a cardiologist, I think home healthcare has already penetrated to a small extent. There are remote ECG monitoring devices. There are pacemakers which are being monitored remotely. If my patient has a defibrillator shock, I pretty much get notified instantaneously through all the protocols that are there. If somebody has an arrhythmia or they feel funny, nowadays people just send me snapshots of their Apple Watch. They're like, hey doc, this is my latest ECG, what do you think? And I'm like, oh, this is normal, don't worry, you're just anxious, this is nothing abnormal. So that kind of home health care, if I was to call that, is already going on. To answer your question, Dr. Mehta, that where do we see the hotel/hospital going into kind of a transition care unit where you go, you get better, you become a little stronger, more of a rehabilitation center, if I was to use that word. These centers are actually very prevalent in America. When I used to practice over there, when I worked over there, I practiced over there, I was told on my first day at the job that, listen, patients from here don't go home. 80% of them usually go to another transition care facility, they get better, they get stronger, then they go home. A lot of that also had to do with the social status over there, where people are primarily living by themselves. Older people are living by themselves. They're not living with their friends and they're not living with their families who are there to care for them. But that is where I see a lot of other home health care, transition care is sort of happening in the next few years. There's one very important thing that we have to consider when we do that. Actually, two very important things. The first is quality, and I think multiple people have mentioned that, to try and get good quality metric of the person who's going to be delivering the care. There is a lot of discrepancy in the quality. To give you an example, in the hospital, there's a nurse. Now, this is a junior nurse. She may be a trainee nurse. She may be just out of training. And when she's giving an IV antibiotic, there is a senior nurse over there who's overseeing the junior nurse's job. Now, when you go into home health care and there's only one nurse, it is that nurse and only that nurse who's doing that. So that's where the quality comes in. The quality has to be really standardized. And the other thing is accountability. If that nurse makes a mistake, who's responsible? How are we going to deal with that? Because the family may or may not feel comfortable. You know, right now if you go to a hospital and there's a mishap or there is a medical error, the doctor is the face and the doctor gets the brunt of it, or the hospital gets the brunt of it, and rightfully so, because they are the service providers. But at some point there will have to be a definition as to who is going to be the accountable person in this entire ecosystem. But I think this is great work, and I really look forward to seeing and participating and being a part of this ecosystem as it grows.
No, wonderful, Samir. And I think you brought out a very important thing. When we integrate systems, we could do digital integration, we can do financial integration, but the biggest integration comes if it comes as trust. Yeah. And you know, as a clinician, if you tell your patients you're fine to go back, don't worry. I think that's going to be the biggest impetus as we go ahead. Thanks. I'll next go to Amitabh, and you know, continuing on you know what Mayank also alluded to. I think the whole idea is there needs to be a trigger when you move from the hospital to home, but there's also a trigger of what home health care can't do, and you need to go back to the hospital. Also, from a perspective of, while we could talk about it, I think to concretize what really gets covered, and you know, what are the limits of home health care and what gets reimbursed? How do you see that paradigm develop in the next 2-3 years?
Yeah, thanks, Dr. Rana. I think a very important point in terms of when we come to defining these standards, you know, it's important also to understand that it has to be both an approach for step down as well as step up, in the sense that you also will have to have triggers that will give you clear emergency signals that, you know, the person has to be taken back to the hospital. It's not only one way, right, that people moving to home from the hospital. So that's important because patient safety is paramount, and that will be important to building trust. Before I go on to, you know, the specific point that you asked for, let me also say that apart from various other points that we discussed, advocacy is also going to be an important element for building this whole ecosystem, wherein patients are able to, you know, start believing that something like this is possible, that it's okay to, you know, leave the hospital after the 3rd day or the 4th day, say in case of a medical management case, in case of fevers or gastro cases where it's just monitoring and say simple IVFs to be administered and which can be remotely monitored, and you know, they're going to be fine. So the clinicians, the providers and the rest of the fraternity will have to start advocating this so that this trust building starts happening, because fundamentally as payers, as insurers, you know, while the insurance industry has been doing a lot to bring in more transparency and build that trust element, but there's generally a trust deficit, right? If we are trying to advocate something, it's not taken in that sort of spirit. So it's important that the whole ecosystem sort of moves in that direction. And for that, the point that you made, that, you know, well-defined packages. For example, today we have very, very well-defined packages on a lot of surgical procedures that we operate with a lot of providers. And it becomes a very simple way to administer them on a cashless basis. Similarly, I think things will have to evolve on medical management and a lot of other cases that can be administered at home, so that once we define those packages, it's clearly understood that it can happen on a cashless basis. Insurers can have those trigger points that when the patient moves out, or actually they need not even go to the hospital for certain type of cases, and then the whole provider is paid directly from the insurer. So that's an important element of what we are trying to build going forward as far as home health care is concerned. And I think the role of technology, the way it is evolving now, and a lot of you know, digital applications, the way they are going to help us in remote patient monitoring, will go a long way in terms of ensuring that some of these protocols can be actually administered well. Thank you.
Thank you, Amitabh. I think very, very important points about, how do we get the nitty-gritties of, what are, just like the packages, I think if you look at the acute care packages in hospitals, they've taken over a decade before we really have packages which are accurate. So maybe the time to start off is right now. Rishabh, I'll come to you next, and Dr. Madan Gopal also referred to this. One of the issues in India, especially in the public healthcare system, is that we have multiple schemes running to give financial access, right from a PMJY, a CGHS, state schemes. And if we were to look at this actually with a public health lens, how do you see the convergence of schemes happening before there's consensus on what you offer as home health care?
Dr. Rana, first of all, thanks for having me here. I am representing Baxter India. Before I jump into the answering a very interesting question from your end, this is a space I have personally been following up for a few years. I remember 10 years back, my grandmother was around her final stages of life, and we had to get a nurse at home, which took us quite a while to kind of figure out how do we do that, what are the logistics. And it is so good to see all these things coming to foray, coming to life, and getting organized in a way. And of course, thanks to a lot of efforts which have gone behind this from a lot of people. Specific to your question, Baxter has been involved in a therapy which is very close to home, which is called as peritoneal dialysis, which is a form of dialysis. And to give you a parallel example, there is a universal health insurance which the government is working on, which is called as PMJ. It's an outstanding program to cover the people with the kind of magnitude of population we have in India. It takes a lot of effort and a lot of work. To be able to do that, kudos to government. But specific to peritoneal dialysis, once a patient has to go on it, the precursor for that is a procedure which is called as catheterization. Now, PMJ does not cover catheterization, which means out of over 2 lakh ESRD patients which are diagnosed every year, a lot of them are not able to access this scheme because the catheterization is not covered. You flip to the other side of the policy, which is PMNDP, which is Pradhan Mantri National Dialysis Support Program. It allows for catheterization, and those patients are able to access the peritoneal dialysis, but the challenge is these guys have to go back to the private hospitals where capacity is a challenge, and these guys don't get, or these patients are not able to access dialysis because of capacity issues. So one side there is a capacity issue, while other side there is an access issue because this is not covered. In an ideal world, if both of these policies were to converge together and a patient was able to access both the things, it would help cater peritoneal dialysis specifically to a lot of patients who need it and are not able to get it because the two policies, both from the government end, are not talking to each other. So while a lot of good work has gone into it, if we can converge these things together, it would lead to a better healthcare access to a lot of patients who need it. I'm giving an example just from peritoneal dialysis because I'm very close to it, but I'm pretty sure there are a lot of other therapy areas which again go unaddressed because of this. So that would be my take, but again, thanks for the interesting question.
No, I think that was a wonderful point. As we build the ecosystems, you can't have things which are separate. It all needs to coalesce towards one cause, because otherwise, at the ultimate, more than the provider or the payer, it's the customer who gets left out, the patient who gets left out, if it's not built with enough insights. Mahesh, I'll come to you, last, and the whole idea again. You've been in this space for a very, very long time, and do you really think we've now reached the inflection point? And what are the building blocks we should put in, like Meena said, so that this ecosystem, rather than evolve, actually kickstarts and goes to the next level?
So I think quite a few of the points have been covered in bits and pieces. I'll just put the perspective. Today's home health care is largely focused around post-discharge care, right? And the biggest challenge is to get that important stakeholder called hospitals on board into it. What are the challenges that we are seeing there? The first one is the mindset. What we have done for centuries together is the right way. To migrate to anything, it takes a pandemic like COVID to shake our mindsets. Hopefully that has opened certain eyes. Now the hospitals are a little more open to see the entire healthcare delivery from a different perspective. So I think engaging the hospitals, now what is this pitch that you are going to give to the hospitals to make them excited? The ALOS story does not work in India, particularly for the private healthcare system. The day you say that, the surgeon is unhappy, the CEO is unhappy, the managing director is unhappy, right? Because your entire revenue model is built around that. So what is the value proposition that we are going to be doing around that? And I think from the experience of being part of a large private hospital and also being onto the home healthcare provider side, I think the most important thing, at least with the COVID that has come, is how do you offer a differentiation strategy today? Let's look at CABG or TKR, which is the largest revenue earner for any hospital. 40% of these patients are not from the same city. And there is a huge dip in continuum of care. So what does the patient do? He's staying 1 week cost of staying into that same city. And then he's spending for a physiotherapist or a doctor or a nurse to come and take care of him in the hotel, etc. So there is a lot of additional cost or opportunity cost which the patient is paying into that. So I think this differentiation strategy and actually mapping the patient from where they are doing and hand-holding them to the end point would be a great story to tell to the hospital providers. Stickiness to the customer and LTV is far better than saying that we'll be reducing your length of stay and improve your average revenue per occupied bed. This story really doesn't work into the hospital. The other thing is, this is from the hospital point of view. The second important stakeholder to be integrated into this is diagnostics, very clearly. The third part is the medtech. And how do we get, the large challenge for hospitals today or even for any healthcare provider is, how does the care continuum flow and how does the data flow? There are gaps in these two things. If I partner with multiple stakeholders, there is a huge variety of my data going out and nobody wants to risk that. So this integration on the care continuum, on the quality and consistency, secondly on the data flow integrated is extremely important. The third piece is around the payer side. And it's very heartening that we have insurance guys which are open, but it's not an easy path. If you look at historic data of how insurance has impacted home healthcare industry, there has been a honeymoon phase initially where it gave a huge impetus to the industry, but later on, only people who had efficiency of scale could survive that. If you look at the US market, etc. Otherwise, for smaller players, the entire insurance play became a very difficult margin play. Even today, home healthcare is a very low EBITDA business in the evolved markets also. So while insurance is necessary for impetus, it's important for all stakeholders to come and create a viable and sustainable model into this. And the last piece is around the skilling aspect. And I think unless there's a good regulatory framework coupled with the skilling, both just independent of each other, will not give the necessary output that is needed for this industry.
No, thank you. I think you put the 4 building blocks very well, and I think them coming together. But I think the whole idea, ultimately, it has to be viability and sustainability for any industry. So we love to go on, but the organizers saying we already run out of time. So I think it was a really enthralling conversation. We spoke about home health care not only being limited to the private sector, but how does it also encompass and put in the public sector? How do those work out? We spoke about how, integrating trust is important. It's just not, and the role of the clinician as you brought in. The role of how do we make sure that there are no lacunae in what we do. The peritoneal dialysis was an excellent example. And how maybe the time to act is now as we build up packages and take this to the next level. I would like to thank all my panelists, and I'd love to thank the audience, both physical and virtual, for this wonderful section. Thank you.
Thank you.
ये हटा दो, ये हटा दो, इसको बंद कर दो.
Actually, अगर आप ऐसे दे सकते हैं तो it's more comfortable क्योंकि किसी और की भी
Hi, while the stage is being set, I would like to formally give a vote of thanks to all the people who have contributed for the Home Healthcare Roundtable. It's been terrific 2 days, very power-packed sessions, and Siddhartha also already mentioned that in his formal vote of thanks. Thank you so much for being with us, and what a wonderful roundtable it was. My special thanks to Dr. Madan Gopal, Senior. Can we have the house in order? I think, yeah, sorry. I just wanted to give a formal vote of thanks to all the people who have contributed for the home healthcare study. My special thanks to Mr. Madan Gopal, Senior Consultant, Health, NITI Aayog, and my special recognition and thank you to all the panelists who have physically joined and virtually also. Dr. V.K. Paul, Honorary Member, NITI Aayog, Mr. Arun Kotwal from NHSRC, Dr. Ranjan Kumar Chaudhary, NHSRC, Ms. Manmeet K. Nanda, Joint Secretary GPIIT, Shri N. Yuvaraj, Joint Secretary DOP, and Mr. Vikash Sheel, Additional Secretary and MD NHM. Thank you so much for all your valuable contributions. There were a lot of other people who have also contributed for this paper. Let me start with Mr. Mayank Bathwal, Gaurav Tripathi, Anuradha Sriram from Aditya Birla Health Insurance, Dr. Gaurav Thukral and Vivek Srivastav from Healthcare at Home, Hari Thallapalli and Dr. B.N. Chaudhary from Call Health, Dr. Harish Pillai and Dr. Suraj K.M. from Asterium, Dr. Krishna Kumar Sivaprasad from Star Health and Allied Insurance, Dr. Krishna Mehta from One Life Home Healthcare, Dr. Mahesh Joshi from Apollo Home Care, Ms. Meena Ganesh and Dr. Vishal Sehgal from Portia Medical, Ms. Nanki L. Singh from ProTribe Services, Dr. Narayan Swami, who prefers to be called as Rahul from One Life, Pradeep Sen from Tribeca, Dr. Rajiv Sadanandan from Health Systems Transformation Platform, Mr. Rajiv Mathur from Critical Care, Mr. Rohit Sate and Sudhakar Mariapadi from Philips, Mr. Sumit Singhal from KINS Healthcare, and Dr. Venu Gopal Kokuntala from Century Super Speciality Hospital, and also Mr. Vipin Pathak from Care 24. My special thanks to the PwC team led by Dr. Rana Mehta and supported by Dr. Vijay Raghavan, Samhita Bhakta, Dr. Kanchan Raghuvanshi and Sonali Dania, who have always heard us and have been flexible with all our demands. We are immensely indebted with all the industry leaders who joined us from across the spectrum of the healthcare space in India today. We would like to convey gratitude to the Ministry of Health and Family Welfare, NITI Aayog, Department of Pharmaceuticals, and Department for Promotion of Industry and Internal Trade for their guidance and insights. We would like to thank the entire NATHEALTH leadership team and the NATHEALTH Diagnostics, the insurance, providers, senior care, and medtech forums for their contribution to the paper. It is difficult to imagine even pulling this event off without your constant support, leadership, and guidance. I should also thank our generous sponsors for the paper, because without their support, we could not have published this paper. Our special thanks to Aditya Birla Group, Care 24, Apollo Home Care, Asterium Healthcare, Atulya Assisted Living, Call Health, Century Hospitals, Critical Care Unified, Fortis, HCAH, KINS Home Healthcare, Philips, Portia, Tatva Group, and Tribeca Care. I would also like to thank our event management partner, India Attitude Team, led by Bhanu, Shrasti, Shubhang, and the entire team. Our communications partner, AVNWE, led by Nitin and supported by Sharmishtha, Manas, Julia, Samiksha, and Gulshin, and our media partner, Ms. Jeta from HealthBiz Insight. We have finally managed to pull this off only with your support. I must now thank my colleagues from NATHEALTH Secretariat, led by Mr. Siddhartha Bhattacharya and supported by Vrinda Chaturvedi and Anugrah William. They have all fought through tough, long days and even illness to make this happen. My immense gratitude to the delegates who joined us both physically and virtually. Thank you all for making this summit and this roundtable a huge success. Aap sabhi ka tahe dil se shukriya. With now, I would request again Rana Mehta to come up on stage, and we have another roundtable on value-based procurement. I know we are running 10 minutes behind the schedule, so we should just start it. Over to you, Dr. Rana Mehta and Ashish.
Thank you, and this is the last session, I think, today. And as we start, before that, we'll have a presentation on the paper by Ashish. Ashish, if you could run us through.
Is the presentation existing? Got it. Thank you, everyone. A big thank you to NATHEALTH and APAC Med for giving us the opportunity to contribute and develop the paper. To give a bit of context, this paper took a tedious effort of 3 to 4 months when with help of stakeholders from APAC Med, NATHEALTH, we spoke to 15, 16 global experts across multiple geographies, including America, Europe, and Asia. And that's how we culminated into this white paper that got released yesterday. Big thank you to all of you for contributing in this. Beauty lies in the eyes of the beholder, but value lies in the eyes of the procurer. And hence, the key question comes is, how does a procurer look at value? There are multiple aspects. I think a broad definition would be desired outcomes over cost. What sort of outcomes are we talking about? We're talking about patient quality, clinical outcomes, total cost of ownership, patient experience, user feedback, patient safety. And when you're talking about cost, we're talking of lifetime cost and not only upfront cost. Other aspect to understand from a value perspective is the value is attained not in the short term, but over the long to medium term. Similarly, along with cost, aspects around quality and outcomes are also an important factor to evaluate as far as value-based procurement is concerned. This slide captures and compares what the standard procurement, which is a typical L1, compare itself to a value-based procurement, right? And we have looked at it from multiple dimensions. But just to highlight some of the key points, the focus in standard procurement has been lowest cost and looking at the product and minimum, at the most, only specifications. But when we are talking about value-based procurement, the focus is on outcomes. The focus is not at a product, but on a solution. Similarly, value-based, when you're doing standard procurement, the decisions are largely driven by either clinicians or the procurement in charge whose criteria are typically to get the product at the lowest cost. But when one talks about value-based procurement, there's alignment to strategic objectives of the organization, which could be getting the best quality, which could be lowest cost, so on and so forth. The overall objective and outcome then you get in a standard procurement is to get the product at the lowest cost, whereas when one looks at value-based procurement, the objective is to get the product or the solution, but to get the best outcomes. I think that's the key differentiation between value-based procurement and the standard procurement. Multiple stakeholders are involved and there are benefits across the value chain. Government as an entity and being overall responsible from a healthcare perspective gets reduced total cost of ownership, because focusing on outcome means you are reducing your readmissions rate, you are reducing your complications and so on and so forth. Better and healthier patient means more votes. Similarly, from a medtech company perspective, is the benefits are that given the focus on quality, they can sell more innovative products, they can invest more on R&D. Providers, given if the focus is on procuring value-based products, then ultimately the clinical outcomes of that hospital improves, which is a significant rub-off impact on the brand for the provider. Plus also, since total cost of ownership is generally lower, then those costs gets distributed across the value chain. Patients benefit in terms of availing the best quality care as well as reduced cost per se. It's important to understand the steps in the value-based procurement process, and that is an important element of how we differentiate vis-a-vis standard procurement. Starting with the as-is assessment. Procurers need to understand what's the current outcomes and what is it that they're looking for as an outcome from the product or service. Then internal discussions beyond doctors to all the stakeholders involved, right? It could be nurses, could be technicians, so on and so forth. Even the management in terms of what is their overall alignment person needs to be undertaken. Post that, a tender RFP needs to be uploaded or released. The second step is having pre-bid discussions with medtech providers. And this is a very important step because medtech providers then can understand the genesis of the tender, of the reason behind buying that product or service, and then give their valuable inputs, basis which, if there's a need to modify the bid or tender, that can be undertaken. Post which, I think the RFP, etc., needs to be released. Even before that, if required, pilot studies could be undertaken. Once the bids are submitted, providers or procurers need to evaluate the products basis the framework, which is the value-based procurement framework, and there's a slide that we have on that. Broadly, it covers outcomes over cost, right? And outcomes, as I said, value lies in the eyes of the procurer. Somebody might feel clinical outcome is the most important focus. Some provider might feel it is cost. But basis that they need to evaluate, agree on, and then obviously go ahead with the selected procurer. There have been multiple frameworks around value-based procurement globally, and this, when we spoke to all the global stakeholders, we got this input. The most evolved is the MEAT framework, which is getting implemented in Europe. The genesis was the EU directive in 2014, post which a lot of the member countries in Europe have accepted and implemented this. There was aspect of CQU in Australia, as well as VAPRO in Norway, as well as I think there was a value for money framework which got implemented in UK, on which actually MEAT framework has been developed. Multiple countries have to some extent implemented or are already implementing value-based procurement. When we studied, and I think the paper talks about 14 case studies across multiple countries, and I think one should read it. I'm just highlighting the key points, what we found. It works both in the public as well as the private sector. It works well in developed world. It is also started working or being accepted in the developing world. It works across all medtech products, be a simple product of a bed furniture to a catheter, to pacemaker, to a large equipment such as linear accelerator. So it becomes that way a product agnostic. Even different types of healthcare ecosystem. So in even a country with fee-for-service model, or in a country where it's a capitation model, value-based procurement works. And that was one of the key learnings that we got from the case studies that we have detailed out in the paper. Basis what we spoke to stakeholders, basis the case studies we had detailed out and evaluated, plus seeing the Indian context and all the other frameworks, we thought this could be a good reference in the Indian context, right? Where we're talking about 5 pillars in terms of where procurers could see value. Patient outcomes being pillar number 1. Then you're talking about long-term relevance. Then we are talking about efficiency as well as access to care and overall total cost of ownership. In the next slide, as a reference, we have detailed out within these buckets what could be the parameters that as a procurer one can evaluate and give weightages to compare products, right? So as an example, if I'm talking about patient outcomes, so what are the products or solutions that help me reduce readmission rates? What are the solutions that will help me reduce OPD comebacks? What are the solutions that will help me reduce variability of my clinical outcomes? Similarly, if somebody is talking of total cost of ownership, then it's not only the upfront cost, it's the maintenance cost, it's the cost of resurgery, so on. So it's with the cost of capex, it's the cost of upgradation, and so on and so forth. Similarly, when somebody is talking of stakeholder benefits, is it providing benefits across all the stakeholders in my organization? And is it linked to more equity of care as well as sustainability in terms of having the latest technology, and ease of upgradation of that product? To implement such a framework in the Indian context, there is a strong need for all stakeholders to work together. And in our paper, we have detailed out what each of these stakeholders and what role they can play and what action they need to undertake to enable implementation of value-based procurement in India. Starting with the government, and we saw that with MedTech, what happened in Europe, EU had to come up with a directive, right? So that became a policy which multiple countries in Europe have implemented. So a similar policy in the Indian context, which enables state procurement agencies, government hospitals to look at procurement under the value-based procurement framework. Similarly, the focus on quality and patients' outcomes. While even under PMJY, there's a differential rate for NABH accredited hospitals, but there is not much focus on rewarding outcomes. I think that's one area where once the payer starts rewarding outcomes, the procurer will automatically look at procuring quality products. Similarly, there's a need for creating awareness as well as capability within the procurement team of various organizations, because when one is procuring products under value-based procurement, it is beyond looking at only the cost and the financial aspects, but multiple other aspects. So that step also needs to be undertaken. As well as it's always good to have a standard guidelines so that multiple other stakeholders can imbibe from that. MedTech companies need to undertake and engage with both the public and the private providers per se. Similarly, I think they need to focus on getting data outcomes as well as develop risk-sharing propositions. As far as providers are concerned, again, capability needs to be developed along with the fact that pre-procurement dialogue as well as maintenance of data, which today becomes very important, today does not exist in most circumstances, and that helps to create baseline data basis which value could be evaluated. And at last, since I said it's an ecosystem, so unless the payer is incentivizing the provider, it becomes difficult for the provider to incentivize or procurement of quality goods for medtech companies. So payers, if they can evaluate their products, which give impetus to quality, I think it will help in the overall growth of value-based procurement. Thank you. Since we're talking of value, I hope I have added value through my presentation. And I'm hoping that it sets the context for the roundtable or straight table right now. Thank you once again for NATHEALTH and APACMed for inviting us. Thank you.
Thank you, Ashish. And I think a very comprehensive looked at value-based procurement, something which I think needs to be part of the healthcare discourse. So Pawan, I'll go next to you. I think a lot of value gets created by value created that. But what do you think are the top 3 benefits of this as we were to implement it? I know it's not going to happen overnight. This is more evolutionary. But what are those 3 benefits should both the private and the public sector look at?
Thank you, Rana, Dr. Chaudhary, Ashish. I think probably you could start with the first benefit that people would trust utilizing government health care if we fix this value-based procurement. Today, I think all the studies show that 50% reason for people going into poverty in India is a healthcare episode. On the other hand, 30% of our healthcare budget is spent by government. There's something missing there. The English and the math don't add up there. Meaning, if government were spending so much money on healthcare, you shouldn't have people going into poverty. And which means probably there are inefficiencies in the way healthcare is utilized, and probably a value-based procurement would fix that first. And if you say that's the strategic benefit, I'm all for it. And that's why I believe that VBP is probably the way to go. Subsequent to it, or like lower level benefit, is a better outcome. You could get better outcome consistently if you do value-based procurement. You could get episodic outcome with great skilled surgeons, technicians, and people-based one. So if we could get that better outcome and people's trust goes that in this facility, there's quality that we can get, utilization will go up. And with that utilization, half of our poor quality healthcare and access to healthcare problems get resolved. So I would say number 1 benefit is trust in the public health system, which means government gets to spend their money in the best possible way, better outcomes. And from an industry perspective, the moment you have 30% of the money actually utilized consistently in a value-based procurement, suddenly the market becomes attractive for all players to come in and not just some players to play in this government procurement. That I would say are the 3.
No, thanks, Pawan. I think excellent, exactly to the point. Dr. Chaudhary, as we go ahead, one of the things we'll obviously want to know that as the public procurement, where are we thinking? Traditionally, our country has always been an L1 country. Understandable, you want to get the best value, but often L1 doesn't create value. So where are we in the thought process in the public procurement space as of now?
Yeah, thank you very much. First of all, I must thank NATHEALTH and APAC, for giving me this opportunity. Sorry. And greetings from National Health System Resource Center. For my ED, that is General Atul Kotwal, he heads our issue. We had a series of meetings on this issue. I'll just share my views on the public procurement. Particularly, what we are looking, enough is said in the presentation, it was very amply clarified, what do you mean by value? So anybody, a common man or a layman, you ask him, he will say value for money. I should have an item which is low cost, sustainable, durable, and giving me improved outcome. If you recollect, in the COVID era, all of a sudden, there was a craze of having a digital, watch, wearable smart watch with a SpO2. That was the need. That was the need. Right now, once the COVID is relaxed and all that, then people again come back to a simple chronograph, might be. So the need determines the value. So value analysis was always there. You have to understand the value to assign it to an object. Now I'll quote some examples. Recently, I'm undergoing, reviews of many proposals coming from the state. There was one state, I'll not name it, they came out with an innovative proposal of having a full-field digital mammography with tomosynthesis and, stereotactic biopsy. Can you understand anything about it? So it is all mixture of diagnostic, therapeutic, and what you are looking is, I asked, what is the need? Need is to diagnose breast cancer because it's very common, 1 in 20. Then I said, it's already, there is a health technology assessment report in the net public domain. And it's amply clarified that the clinical breast examination parallel with the ultrasonography is the best screening strategy for diagnosing breast cancer. So here the value comes. If you have a well-established procedure, then you understand the value. This value will have an impact in saving so much of money. The other context which I'll say is, in this whole value chain, what we lack is standardization. The technology is developing so fast. If you see the Khan's hyper demand cycle, every other day you will have a new technology coming. But you need not do health technology assessment for all the technologies. That technology itself dies off when the need goes off. I give you an example. So what you require in the long run, like in public sector, we assess and we do the value analysis for uptake after a prolonged research. Is called a health technology assessment, which is maybe of 2 years something. A simple example like hemoglobinometer, which has been done by the DHR. Now we have a screening tool at the point of care in the community for detecting anemia. Similarly, a question came up of hemoglobinopathies. So many people said, no, the gold standard is we should have HPLC. Very true. But where should be the HPLC? It should be to a place where you have infrastructure, you have trained manpower to interpret it. So we suggested that you should use the Nestroff and the solubility test at the community level, which are very cheap, 3 rupees a test, I think, and have an electrophoresis for the screening at the DIC level, and then go for HPLC, whomever you screen. So this is a graded, and believe me, just now I'm coming from GEM, where I was talking about value analysis and value-based procurement. I requested the deputy CEO there, we had a discussion. Okay, when you open a GEM, because central government, all purchases are now mandated through the GEM portal only. In the GEM portal, when you see 4 or 5, companies have projected their thing, they have very nice rating of discount and then 4-star and then SS. I said, why don't you say, are they willing for a reagent rental model? So with the high-end equipments, most of the diagnostics, in the 15th Finance Commission, health grants and all, you have a lot of opportunity, a lot of grants are available. If the suppliers, they propose that, yes, we are ready to give reagent rental, and after 5 years, the equipment is yours, and I've taken over the break-even point, whatever, 5-7 years, and consumables are taken care of by the company, because most of the equipments nowadays in the diagnostic are equipment-specific consumables. So that is actually the value-based procurement model we are setting in the country. And it's all because of the trust, and I'm sure the ecosystem will develop with, our Prime Minister Shri Modi's vision for developing so many parks and standardizing and everything. I think these are few of the practical examples where we can use value-based procurement, always remembering the 4 E's and 1 S, which Ashish has amplified it. And thank you. I'll stop here, sir. Anything else you can ask me?
No, I think that was very encouraging, because I think the paradigm of both the government as well as the private sector working together becomes really important in this. Dr. Hari Prasad, nice to have you online. I think one of the biggest things, and you being part of India's biggest provider, is that value-based procurement is a collaborative effort, both with the provider and the medtech companies. So what are those areas where you really feel, because at the end, you're working together to create value, not for ourselves, but for the patient. So what are those building blocks we should put in that this becomes part of the procurement, not only in the public sector, but also in the private sector?
Thanks, Rana. I always say this, reward for a job well done is a tougher job. And I'm seeing that here. You did a great session just before this. So you got one more session immediately after that. So well done, and keep going. And I think it applies to healthcare in India too. I think we've reached a long way in terms of providing access to healthcare first, and then it moved to providing access to quality healthcare, and I guess now we are moving towards providing access to value-based healthcare. And unless we understand this, we would not be able to deliver what is going to be the expectation of the community, the policymakers, and the government. And value-based healthcare is heavily dependent on value-based procurement, because value-based healthcare is, in my terms, nothing but to deliver more for less. That is, deliver better quality, deliver, treat more number of patients, and at a lower cost. So I think that is the basis of value-based healthcare, and the most critical role for that to happen is that of value-based procurement. And I think procurement was, for many years, a transactional thing between the producer and the provider, or the intermediary and the provider. And then it gradually became partnerships where, the tech providers started partnering with the healthcare providers in providing technology. But now I think we need to move towards a relationship. The procurement needs to be a relationship management between the different stakeholders who are involved. And unfortunately, what has happened today, at least in the private sector, is procurement is becoming more of a marketing tool. If somebody has got a 3 Tesla MRI, then I should also have a 3 Tesla MRI, otherwise I will be looked down upon. Whether there's a need for it, whether there's a demand for it, and as far as I know, with my limited knowledge of healthcare, 99% of MRIs required can be done on a 1.5 Tesla MRI. But most of us are moving towards 3 Tesla MRI because we don't want to be looked down upon by when we are compared with the competition. On the other hand, if we all collaborate together along with the tech providers and have 1 or 2, or depending on the need, to do that 1% of the MRIs which require the 3 Tesla MRI, I think that is going to be where value will be delivered. On the other hand, what we're doing today is we are procuring the 3 Tesla MRI, which is much more expensive, and we are charging higher for the entire 100% of the cases, whether they needed the 3 Tesla or not. So I think the value-based procurement is a must for the future, is a must not just for the providers or the tech companies, but I think it delivers maximum value to the community and to the individual within the community. As was said right at the beginning, cost of healthcare is becoming a challenge, and everybody is working towards bringing down the cost, making it affordable, and the improvement in technology or the newer growth in technological aspects is not helping it in any way, because there is a continuous stream of inflow of newer technology coming in, which is only increasing the cost with a doubtful, I'm being very careful with while using my words, with a doubtful benefit in terms of outcome and improvement in the quality. So I think we need to make sure that whatever rupee spent is spent on improving the value that we deliver to the end recipient, that is the patient, and only then would we be able to get into a value-based healthcare system.
Thank you, Dr. Hari Prasad. I think that's very important to get the private sector perspective, and I think we are all on one line. Dr. Jitendra Sharma, can you hear us? We've not been, okay, we can actually see you. So I think one of the biggest imperatives in India is, the whole Atmanirbhar, Make in India. And we're seeing a whole set of medtech zones which are coming across this. I think when we look at that, that is actually to, increase the supply. But how do you actually increase the demand? Because if you look at it overall, medtech penetration in India is still very minuscule globally. So how do you see value-based procurement? Because given that we are the second largest population in the world, we should have the second largest usage of medtech in the world. But we probably over 100 places down on that. How do you see value-based procurement being an impetus to this?
Thank you very much for the question. And I see my friends, Mr. Pawan Chaudhary and Mr. Hari Prasad, all there. So I would lean on to their shoulders also and Mr. Pawan Mogarjka on the other side on the stage. I would lean on to their shoulders also to get some inputs from them if I fall short of my comments. So there are 4 things. One, more and more innovations would come in. You cannot stop it, you shouldn't stop it. Now look at the anomaly. By definition, an innovation is supposed to be unique. Yet, to procure an innovation, you need 3 quotations. How do you procure? If something is unique, it's going to have a singular quotation. How do you get 3 quotations? Which means rules need open-minded, deliberative, discussive change. The second point is when I started health technology assessment in India in 2012, which my successor, Mr. Chaudhary, is now ably leading in NHSRC, way back in 2012, 10 years ago. The fundamental principle of HTA was a good product need not be sufficient for good quality outcome. A good product plus a good service is equal to good outcome. And it's very necessary to isolate the impact of good service from the impact of good product, which is also a complex situation. You can have, as Dr. Hari Prasad mentioned, literally a 3 Tesla MRI, but not a great radiologist like Dr. Harsh Mahajan or one of his trainees, and you can still end up with a garbage diagnosis. And therefore, health technology assessment is necessary to differentiate the singular unbiased role played by the product itself. And that's something that must guide procurement. The third thing is even more complex. Now we have imaging resolution mapping softwares that can actually get us, and we produce CT scans and MRs in my own facility here in Vizag. There are image reconstruction softwares that can now give a 64-slice CT resolution just by image construction on a 16-slice CT scanner. It's possible today, which means value-based healthcare can actually reduce the cost of product as well as cost of service. It should not be looked upon as a hidden bait to gain reimbursements by the industry. It can actually introduce cost effectiveness in healthcare if we could smartly differentiate and deploy these solutions. Now, the important thing is, today we sell products as products. We sell an MR as MR. Whereas the outcome of an MR can last for 10 years. It would be used constantly over and over again. So when you use quality-based procurement system once, you might be falling into an unknown zone in 7th year or 9th year. And therefore, it is also a time where value-based healthcare must get integrated into innovative procurement and selling strategies. Not just procurement strategies of the procurer, but also selling strategies that are innovative by the seller. What if this MR were to be combined with cloud space storage, tele-reporting and analytics, and sold as cost per scan? Imagine if there were to be entities that could actually add cost of MR annuitized over 10 years, reporting, storage, analytics, and the cost of interest and profits, and sell it to the hospitals as cost per scan. I think that would give both parties, the buyer and the seller, and certainly the beneficiary, which is the patient, a credible, sustainable approach to value-based healthcare. And my last point is, as it is wrong to assume that L1 always gives you the best value, it is also wrong to assume that L1 does not give the best value. Both are unknowns. So any presumption is wrong. And therefore, unless the outcomes are integrated, outcomes like infection control, outcome like higher accuracy, outcomes like progression-free survival associated with technologies, it wouldn't be possible to convert an L1 into QCBS for want of scientific methods. And therefore, APAC, NATHEALTH, all of us together must actually look at what are those. So it's very easy to classify something as wrong but very difficult to put in effort to convert it into right. And what I'm simply suggesting is, with all the good minds here, at the backyard of country's largest healthcare association, NATHEALTH, we must develop scientific methods for pharmaceuticals, medical devices, and services in 3 distinct verticals, defining and deciding methods that would allow value-based procurement to actually get into a system, rather than calling the current system inadequate, which it is, but then the roads that would make us more perfect are unknown roads. And we would need the guiding lights from all parts of the stakeholder to differentiate between pharmaceuticals that last for a relatively less time, devices that last for a longer time, and services that last lifelong, into concrete formulas which would allow value-based healthcare to get into the system. Thank you, and over to you.
Thank you. I think that was really insightful, because I think we got a lot of points about, one is not necessarily right or wrong, and then this is an evolutionary process as we go ahead. And I think, Dr. Jitendra, I'd like to end, how do you put everything together? At the end, it should come into patient outcomes, and like you said, what's the value of that? So Pawan, next to you, you've been the veteran of the industry. So in a lot of ways, I'll want you to respond to Dr. Jitendra Sharma, saying that, it's not necessarily L1 doesn't get you. But I think there's a consensus that we'll move towards value-based procurement. One, I think the imperatives for that. The second, I think, why do we need to act now? Because healthcare spending is going to grow fast. So if we don't act, what is the cost of our inaction if we don't have a better procurement system, both for the country and finally for the patient? Pawan.
Thanks, Rana. Pleasure to be with you all. Responding to what Dr. Jitendra Sharma said, using beautiful building blocks left by Dr. Hari Prasad, Ashish, and my other friends. So, Dr. Jitendra Sharma said a beautiful thing. Good product is not enough. Good service is also important, because the patient is experiencing value on a long spectrum of experience. So, in case he's being rolled in for CT abdomen, where they mistakenly realize that he has been fed so the CT abdomen cannot happen today, then he has seen loss of value, maybe longer stay also. So that services part or training part is very important. What Ashish said, that value lies in the eyes of the procurer, I fully agree with this. At the same time, I request for a widening of the pupil of the eyes of the procurer, because he should know more before he will be able to really appreciate value in the device or equipment which he is buying. Because a limited idea of value, this is where I disagree with my knowledgeable friend Mr. Dr. J.K. Sharma, which says that outcomes are dependent on outcome achieved divided by rupee spent. That is value. But this definition excludes the interest of the provider. It also does not take into account the impact on the healthcare ecosystem, and it also does not take into account other non-procurement costs or long-term costs. So this is where I feel what Dr. Hari Prasad said. He brought in another interesting concept. He spoke about imaging and value-based procurement, but he spoke about image-based procurement. He says in reality what is happening is that hospitals are vying for better image than each other, which is why they are buying a 3 Tesla even when they do not need one, just so that they are not seen as more ancient than the others. He also spoke about, but there is necessity to do that sometimes. Why it is sometimes necessary to do, if you are having a very good service, but you are not having the right kind of noise making machines, your very good service might not pick up. But the point which he brought out was that can we look at communal ownership of some products? Like for example, a 3 Tesla machine is owned by several people kept at a place where the 3 Tesla deserving patient can go. So this is what I would like to say in response to what has been said so far. And I do feel that if we will not go for value-based procurement, which is very informed procurement, looking at all healthcare and healthcare ecosystem cost and long-term costs, we will be losing credibility, as Pawan Mochrela said. We'll be losing credibility and we will be shortchanging the customer in the interest of spending less, but in the beginning, but overall spending more. Rana.
No, thank you, and I think you articulated it very well. You know, while anything lies in the eyes of the beholder, the vision needs to be actually enhanced, because we can only see what we know, right? We cannot see something we do not know. So finally, I think while we're running out of time, I'll ask Pawan again once to look at what is the roadmap he sees in the next 3 years. This is an evolutionary process, but what are those building blocks? What are the fundamentals? So when we come back 3 years later, we said this was time value-based procurement really took hold in the country.
Thanks, Rana. Lovely points each one makes, Dr. Hari Prasad, Dr. Sharma, Dr. Chaudhary. Probably even before we go into building blocks and think about strategy to put together the building blocks, the first question we should ask is, why do we want it? And from some of the comments Dr. Sharma made, probably I was thinking two thoughts. Who wants to improve healthcare? Is it the medtech? Is it the payers? Is it the providers? Or is it the government, which is probably taking accountability of healthcare? So I would say start point is there. If the government feels that there's nothing much that needs to be done in healthcare and say the right ways are already in place, there's no need for change. And that doesn't answer our 2047 vision, where we want to be actually a player of meaning and impact in the world. Which means our healthcare is not on that mark as of today. You don't need to compare yourself with another country which spends 15% of its healthcare GDP on healthcare, but there are also countries which are delivering much better outcomes at 5% or 6% of their healthcare. Which means India has always had the advantage of choosing the best after everyone else has made an attempt. That's our strength. We move from wired phones to wireless phones, leapfrogging everyone else. So we could do that in healthcare. But the point is, who wants the change? And it has to be the government which has to make that direction for change. Because private willy-nilly has found some form of value-based procurement already. That is why they are seeming to deliver outcomes which attract populace to go and access, even at the cost of 50% of them going into poverty. So the introspective question we have to ask is, who needs to change? It is the government probably which needs to lead this change and say, we want to introduce this so that more populace can use our facilities and not go into poverty. I would like to stay there at the outcomes. Building blocks are, do you want to do VBP in central government facilities? Do you want to introduce VBP in certain devices which actually are very high-end? That is like tactics. If you get your intent right that I want to do VBP because in 50 years, 25 years, I want to be in top 3 health outcomes as a country, then we got to do it. And then the building blocks are very easy. You just have to ensure that the money spent by government first takes care of that best outcome, not lowest cost. It is very much possible, like Dr. Sharma said, that you could get best outcome at medium cost. Need not be high cost or need not be low cost. But don't start with cost first. Start with outcome. And as we make that progress, probably our dollar can get more out of it. But to say Is it medtech which has to sell first, or is it insurance which has to sell first? Wrong place. Because they are comfortable where they are, globally. Which means it is us as citizens and as government we need to start. So instead of going into those building blocks, I would urge and I would stand and probably talk many times on this, saying who needs to change is government and not necessarily industry, because industry, like equal, what you call water and gravity, will find its way to do the revenues. I'll leave it there.
No, thank you. And I think that was very, very well put. And I think we have an example. So I think one of the biggest changes is the government's moving away from a provider to becoming a payer. The largest insurance scheme in the world, 500 million. The example was that was where the US government was in the 1960s. They spent 5% of their GDP on healthcare. Today it's 18%. There's a lesson for us. As we move from a provider to payer, if we don't put in value-based procurement, our country could very much land up where there's a question of viability and sustainability, and not have actually spending on healthcare then can impact our GDP. So I think we have everything going for us, but I think, like Pavan said, we all need to work together to make sure that ultimately this value-based procurement creates value for the ecosystem and we move towards a healthy India. I must thank all my panelists, both physical and virtual, for being a wonderful audience, which again, physical and virtual, and look forward to taking this forward with APAC Med and NATHEALTH. Thank you.
Thank you, Dr. Rana Mehta. What a wonderful session it was. Let me just give you formal vote of thanks for this roundtable. Let me start by expressing gratitude for the immensely kind participation we had from all the panelists. Dr. Jitendra Sharma from KIHT and Dr. Ranjan Kumar Chaudhary, sir, thank you so much for joining us today and giving your valuable suggestions. Mr. Pavan Mutrela, Mr. Pavan Chaudhary, and Dr. K. Hari Prasad, thank you so much for being a wonderful panelist here. And Dr. Rana Mehta, you are always an incredible moderator, so thanks once again. Our special thanks to all the government stakeholders who have contributed for this paper. Ms. Manmeet K. Nanda, Joint Secretary, DPIIT, Major General Atul Kotwal, Executive Director, NHSRC, Dr. Rajiv Sadanandan, former Additional Chief Secretary, Kerala. I would also like to thank our sponsors, without whose generous support we could not have published this paper. Our special thanks to Roche Diagnostics India Private Limited, Abbott Healthcare Private Limited, Boston Scientific India Private Limited, Becton Dickinson India Private Limited, Terimo, Siemens Healthineers, Johnson & Johnson Private Limited, and Medica Bazaar. We are immensely thankful to our industry leaders who joined us from across the spectrum of the healthcare space in India. And a special thanks to the visionaries of NATHEALTH, our past presidents of NATHEALTH, the leadership team of NATHEALTH, and the governing council of NATHEALTH. It is very difficult to even imagine pulling this event without your constant support and guidance. Our true comrades, the ones driving this summit with us, our partners, deserve a special round of applause. Our co-partner in this paper, APAC Med, thank you, Anirudh, and your entire team. Alicia Chang, Ankit Sharma, Shreya Bansal, Mr. Manoj Madhavan from BSCI, and Shweta Bharadwaj from Johnson & Johnson, who are also part of APAC Med. So thank you so much. Our special thanks to the core committee members who have contributed to this paper, Arvind Vats and Jayashree Mapuri from Johnson & Johnson, Amit Garg and Sahjogita Kathuria from Terimo India Private Limited, Gaurav Verma, Smith Gala from Becton & Dickinson, Monica and Ranjita Sood from Abbott, Sadhana Seth and Vineet Gupta from Siemens Healthineers, Vibhav Garg from Boston Scientific, and Vijay Kumar from Roche Diagnostics India Private Limited. I would also like to thank our knowledge partner PwC team led by Dr. Rana Mehta and supported by Dr. Preet Matani, Ashish Rampuria, Varun Karwa, Samhita Bhakta, and Samuel Sundarajan. A big thanks to our event management partner team, India Attitude, and our communications partner, AVNWE, our media partner, Health Biz Insight. We have managed to pull this event only with your support. I also would like to thank my colleagues from NATHEALTH Secretariat, led by Siddhartha Bhattacharya and supported by Vrinda and Anugraha. My immense gratitude to the delegates who have joined us today, both physically and virtually. Thank you so much for making this summit a huge success and this roundtable a huge success. Thank you so much.